also his topics, and then he will be followed by our clinical instructor Hussein, and then later afternoon will be Dr. Hamad Al-Madi. Okay, so I will start. Bismillah ar-Rahman ar-Rahim, wa salatu wa salamu ala Rasulillah, tawakkalna ala Allah. Our topic now, the first topic today, it's head injuries in children. As you know, head injury, it's a very important, actually, problem that we used to see in the emergency department. Of course, there is nothing to be declared, and it is very common in the emergency department, and I think every one of you had a history of head injury in his life. Okay, some of you were mild to moderate to severe, either you or maybe some of your relatives or friends. And as you know, it's a common presentation in the emergency department, and it's considered to be one of the commonest result of the motor vehicle crashes, which result in death, and up to 31% related to head injury among all age groups. This is a study done in state. And usually male more than female, because the male kids, they are more hyperactive. And very important to consider also head injury in shaking baby syndrome to rule out any intracranial injuries. And it's account for annual visit of 3,000 deaths in the United States, of almost 30,000 hospitalization, and almost 500,000 visits in the United States. Okay, this is an age of 14 years and younger. As you know, why we are considering that head injury is very important. Okay, why we have to treat head injury in the emergency department and as early as possible. Our primary goal is to prevent secondary brain injury, which is, causing more edema, and later on as a complication of hernia and stop breathing and causing, arrest. So this is very serious issue. That's why emergency physicians should take it serious when you have any patient coming to the emergency or any child coming to the emergency with head injury. Luckily, mild head injury is the most common, which is 80%. And the rest, 20% distributed equally between moderate and severe, with 10% of each. And we can label, this is one of the classification of head injury based on the Glasgow Coma Scale. Mild, we consider it from 13 to 15, moderate 9 to 12, severe less than 9. And luckily, 80% of head injury, usually it is mild. And this is the confusing. It is good for the child to have mild head injury, but for the physician working in the emergency department, it is really difficult, because in these cases, either the patient will go home or he will go into moderate type of head injury. That's why we have to consider all the factors and how to approach these cases very well. There is a different classification based on closed head injury or open head injury. As you can see in the picture on the left side, this is open head injury, while the one in the right side, this is what we call it petal sign, ecchymosis behind the ear. And there is another we call raccoon eyes, which is below the eye, below the eyes, and indicate a basal skull fracture, which is a closed head injury. So we will start by case scenario. I'm going to start with this case, and I need your participation, please. So I'm looking at the chat. We are going to chat also to see your response. This patient who is 6-year-old boy slept in a wet service, okay, and developed, and he lost his consciousness for almost 1 minute, and he was brought to the emergency department 1 hour later. On initial assessment, he had a normal vital signs and Glasgow Coma scale of 14/15. Physical examination, full examination was normal, apart from small occipital contusion. So, what do you think? What's wrong with this child? Yalla. We have Samia, we have Rihab, and we have, okay, Sabah al-Noor. Yalla, you have to answer. Hind, also, good morning. So what do you think? What we should do for this patient? Someone was asking, he has a loss of consciousness. Yes, there is a, okay, and there is an occipital contusion. Okay, so CT brain, somebody, most of you, they were asking for CT brain. Let's go and see. And some of you said observation. Okay. Okay. So how you will manage this patient? Most of you mentioned that we should, half of you actually, let's say observation, and the other half, they said we should do a CT scan for this patient. Okay, so this is a mild head injury. Would you do an X-ray for this patient? Plain film, radiograph? Yes or no? Ahmed or Abdullah, okay, no, but some people, they said yes, good. Fatima, okay, yes, yes. So some of you said yes, we'll do an X-ray, and the other groups, they said we don't have to do an X-ray. Okay, let's see the answer. Well, skull film radiograph are not recommended in the evaluation of mild head injury. It is not anymore recommended, okay? Although the presence of a skull fracture increases the likelihood of intracranial lesion, and its sensitivity is not sufficient to be useful screening test. So sometimes even they said, if there is a negative finding in skull film, it doesn't rule out intracranial lesion. That's why it is not anymore indicated, and it may mislead the physician. For example, if you do an X-ray and there is no fracture, no skull fracture, it doesn't mean there is no intracranial bleed. So it is not anymore recommended. But if you are, for example, in a periphery, an area like, let's say, Ar'ar, or, some areas where they don't have Sharura or Arar, whatever. I think most of the hospital now, they have CT scan, which is more important to do rather than doing a skull X-ray, because a skull X-ray, it is not anymore, and it is sensitivity, it's not sufficient, okay, for useful for screening patient with intracranial injury. And sometimes, as we mentioned, this is a very important, it may mislead you, especially for those who has a negative skull finding. They will say, oh, his X-ray is normal, but still, you cannot rule intracranial bleed. So skull X-ray, as per American Academy of Pediatric recommendations, is not anymore recommended, unless in some areas where they don't have any other facility, okay? Or there is a penetrating injury and they need to know where is the extension of this injury. So what is the indication of CT scan? Can somebody tell me? Okay, the breast skull fracture, absolutely. We should do CT scan, okay? X-ray, it won't show very good, actually, the breast skull fracture. Loss of consciousness, good. If you have a worrying sign, if you are thinking of bleeding, yes, but signs and symptoms, okay? If he has a history of seizure, okay, or age less than 3 months, severe mechanism, excellent, excellent, or convulsion. So here, if the Glasgow Coma scale less than 15, 2 hours after the injury. Yani 2 hours after, still he has a Glasgow of less than 15. He has a neurological deficit. He has an open skull fracture or signs of basal skull fracture, like this one in the picture, or like raccoon eyes, or there is something common. What is the signs of basal skull fracture? Those who knows. Okay. Okay, nasal bleed, good. Or rhinorrhea, which is CSF leakage, okay, through the nose or through the ears, otorrhea, or raccoon eyes or battle sign, okay. Vomiting more than 2 episodes, okay, or frequent vomitings. Extreme age, like those who are more than 60 years of age or those who are less than 1 year. We have to be careful. Now they are taken less than 6 months, but you have to be very careful. According to the American Academy of Pediatrics, less than 1 year, it's important to consider CT. Retrograde amnesia, he didn't remember anything before the head injury. And severe headache, this is very important. Okay, severe headache. Sometimes somebody is coming with head injury and he is holding his head of severe pain. This is an indication to go ahead and do CT scan, even if there is no history of head injury. If you have a patient presented to the emergency holding his head and screaming of pain, of severe headache, you have to, and he said, if you ask him a question, is this headache, is the worst headache you have it in your life? He said, yes, please. And he cannot even talk of the, because of the severity of the headache, you should go ahead and do CT scan, because sometimes there is what we call it rupture of, arteriovenous fistula, rupture or whatever there in the brain, okay? Let's go to the second case. So for this patient who we just saw, because of there is a brief loss of consciousness, but his examination and everything was okay, usually we prefer to keep him for observation in the emergency department for like 6 hours. Okay, especially if the rest of the examination were unremarkable. The abrasion of the scalp, which we mentioned it, it's not an indication to do a CT scan. Let's go to case number 2. You are evaluating a 2-year-old girl, okay, who fell off a swing and hit the back of her head on the ground, approximately 1 meter below, and she lost her consciousness for 20 seconds. She cried, and she was consoled by her parents, and she did not vomit. And her parents say that she seems to be back to her usual state. What do you think? How you will manage this girl? Okay. 2 years old, she fell on the ground of 1 meter height, and she lost her consciousness for 20. Basima, she mentioned observation. Amal, she said CT because of loss of consciousness and the mechanism. Okay. Keep under observation. This is Khadija. Okay. Keep observation, Ahmed. Keep observation. I think, yes. Personally, I will go with observation. Let's go to the examination first before, okay, make our decision. She had like 3 centimeter cephalohematoma without step off, okay, and no laceration or abrasion. Her vital signs looks normal, okay, Glasgow Coma Scale 15, no neurological deficit. She cries inconsolably, and when you approach her, okay, she is very anxious, and when you are away, she is very quiet. No other injuries. Okay. How you will manage this child? Some of you said observation, and the other group, they said we'll do a CT. In these cases, to be honest with you, it is based on in your decision. Okay, if you feel like, for me, as like I've been working in the emergency for more than 20 years, I will observe the child. But someone who's a junior, and he said no, because of the history of there is loss of consciousness of less than 20 seconds, and there is a cephalohematoma of 2 centimeters, and there is some, and she's 2 years old, I will go ahead and do CT. Nobody will blame you. Okay. But although, according here to our recommendation, they said a thorough history and appropriate physical examination and neurological examination should be done. According to us, it's negative. Observation in the clinic, office, emergency department, or at home under the care of a competent caregiver. Like if the mother well educated, if anybody is okay, I will give her the head injury instruction sheet, and I will tell her if there is any concern, you can come back to the emergency. And using CT scan, skull radiograph, or magnetic imaging, MRI, is not recommended in such cases. Okay. However, as I told you, if you feel like you are, yes, here somebody said because of the cephalohematoma, frontal or no harm, blood supply to the skull. Yes, I agree with you. So there is no indication to do a CT. But if someone feels like, okay, I will go ahead and do CT scan because I want to make be in the safe side, I think this is one of the causes to keep patient in the emergency department and cause overcrowding by doing unnecessary CT. What is the initial evaluation and managing the child with minor closed head injury with brief, less than 1 minute loss of consciousness? We know that it is a very minimal percentage that they require neurosurgical intervention, only around 2 to 5%. A thorough history and physical examination, neurological examination should be performed. This is the approach. Observation in the office clinic, as I mentioned before, for a minimum of 6 hours, 4 to 6 hours. Cranial CT scan may be used, as you can see here. It's may be used. It is not absolute indication, okay, or not indicated. The use of a skull X-rays as an initial management of children with minor closed head injury and loss of consciousness is not anymore recommended. Okay, and we have to give them a printed instruction, should be given to the parents or the caregiver. Okay, and they can come back to the emergency anytime if there is any concern. I know some of you are worried because head injury, especially minor head injury in the emergency, it's a nightmare for emergency physician. Sometimes, emergency physician wish to have like moderate to severe because I know what I should do for this patient. But sometimes when you have a minor head injury, you are afraid to send this patient home, okay? And then he come back with severe or complicated, and that's why we keep them in observation for a minimum of 6 hours. This is according to the American Academy of Pediatric. There is so many guidelines actually for head injury. And the most important and the most useful one that we used to apply most of the, we call it Ebeneferen. There is other guidelines, but the most important that we are using Ebeneferen. If you know, what does it mean, Ebeneferen? Stand for what? If you know. Ebeneferen. Ebeneferen, it is for Pediatric Emergency Care Applied Research Network. Okay, this was a study done, I think in 2009, if I'm not mistaken, okay, by Kipper, and it was based on their study. They collected data in a huge number of children, and based on that data, they review their laboratory CT scans, and they decide based on these studies to make the decision when you should do CT scan, okay? Or when you should consider significant head injury or important head injury. If you have like a patient who is, what is the predictor? If you have a patient with altered mental status, scalp hematoma, loss of consciousness, severe mechanism of injury, palpable skull fracture, and acting abnormal perparence, okay, this is considered a significant head injury, and you should go ahead and do CT. And usually the specificity and sensitivity is 100%. So positive finding will be in 100% of the cases. So it is very important, okay? This is in less than 2 years. Excellent. In age of 2 years and above, okay, when we should consider a significant head injury or important head injury, if there is an altered mental status, he's very drowsy, or loss of consciousness for more than 1 minute, history of frequent vomiting, severe mechanism of injury, signs of basal skull fracture, and severe headache, okay? And usually these patient, if they have all these, it is very sensitive and very and specific of 96.8% with negative predictive value of 99.95. So this is a very important. When you have such finding in your patient, then I think it is, you can go ahead and do what we said, a CT, okay? This is also Bicaren, as I mentioned here, their recommendation for CT, and this is a very important. If the Glasgow Coma Scale continue to be less than 15, and there is a signs of altered mental status like agitated, somnolence, repetitive questioning, slow and not responding to questions, and palpable skull fracture, if it is there, go ahead and do CT. If it is not there, go and by examination, if there is any occipital, parietal, temporal scalp hematoma, loss of consciousness, dangerous mechanism like motor vehicle accident with ejection, or death during the accident, okay, or he was like crossing the street and hit by a car and, you know, jump, and the not wearing helmet, or there is like, you know, which is very important, parental concern, and this is very important. Most of the time the family, they are coming and they are asking for CT for a stable child, but you have to explain to them, okay? If he has one of these, you should observe versus CT on the basis of physical experience, like, you know, as I told you, somebody who's expert in emergency, he can say, okay, I don't think he has a significant intracranial injury. You can observe him in the hospital or in the, I mean, in the emergency for 6 hours, 4 to 6 hours. If there is no any change in his behavior, he can eat, he can drink, he can sleep, by the way, because I know some of you were asking why some of people, they said we shouldn't allow them to sleep. No, you should allow them to sleep, okay? And just, but under monitor, observe the way they are breathing, okay? Multiple findings, worsening symptoms, or the age under 3 months, okay? Bye. Parental preferences. Okay. You go to the next slide. I have some problem here. Okay. Children more than 2 years, as we explained before, I don't want to waste time. So let's go to the third case. This is the third case, okay? 4 months old. And this is, I need your attention, please, because this is a very important case. And we usually see these cases in the emergency department. Okay, 4 months old was brought to the emergency department, and his parent reported he was vomiting after meals, sleeping more than usual, and lack motivation. It sounds like he has a viral infection. If you just, forget about the lecture that we are given head injury, but if you have a child who's coming 4 months old, because according to the mother, he has some vomiting after meals, with sleeping more than usual, and he is a little bit less active. Sounds like viral infection. Okay. My voice is not clear. Yes, okay. Because someone said he cannot hear my voice. So anyway, this child or this baby, 4 months old, 11 days later, the child was still having the same symptoms. And they brought him to the emergency and become dehydrated with Glasgow Coma scale of 12. So what do you think wrong with this patient? Anybody, any suggestion? Sepsis, excellent, Zahra. Any other? Sepsis, yes, could be sepsis, absolutely. Anything else? Meningitis, yes, you're right. What else? What else? Related to our lecture, yalla, I made it easy for you. Occult pneumonia, possible, yes. There is no history of trauma, nothing. The family, they deny everything. Infected, UTI, ventricular hemorrhage, shaken baby syndrome. Carol, yes, excellent, Carol. Lisa, yeah, excellent. I think this is our nurses. Excellent, yes. Khulud, yes, very good. I think, Lakshmani, or I don't know. Anyway, this is good. I think you are, yeah, your diagnosis, yes, it is a shaken baby syndrome. We did a CT for this child, and as you can see here, there is subarachnoid hemorrhage. So this is most likely shaken baby syndrome. So you have to think about this case. Every time you are seeing patient coming to the emergency and the history is not compatible with their presentation, okay, and not clear. So, and this, as you know, shaken baby syndrome, it's a preventable and often severe form of physical child abuse resulting from, shaking the baby and infant by their shoulder or arm and causing a lot of damage to their brain. And it may result from, yes, as I mentioned, and at least one of every babies who is violent, they die. So 25% death. And this is why we should have a high index of suspicion when we are seeing these cases in the emergency department. I remember in our emergency, that was many years ago, we had a patient who came with like vomiting and not behaving well. So family were instructed, he's about like less than a year old. And we sent him home after instructing the family and everything. Then they came back again with the same presentation. The third day or after 1 week, he came and he was already brought by the family dead to the emergency. And thereafter, taking off all his clothes, we noticed there is some bruises all over his limbs and on his chest, and some marks, cautery marks, and so many things. I think full examination and assessment and high index of suspicion in these cases should be considered, because you are saving the life of a child. Okay, so especially when they are giving you a history that is not clear. Okay, and you feel like your examination and the history you are taking is not compatible with your findings. And nearly all survivors of shaken baby syndrome suffer serious health consequences, including mental retardation and developmental delay, cerebral palsy, severe motor dysfunction, blindness, and seizure. That's why it is a very important, actually, to diagnose these cases as early as possible to avoid this complication. Okay. Clinicians should observe for the following and initiate further investigation. Now we have the child abuse committee in every hospital, scan team, and you don't have to, I think, and they, as a nurse or as a physician, you have the full authority to contact the scan team, okay, and nobody will blame you, even the family themselves. Because the scan team, they won't tell the family that Dr. Al-Fayfi or Carol or whatever, they are the one who call us because they are suspecting a child abuse. No, they will approach the child in a different and appropriate way, and they will make sure if he is really abused or not. Okay, and I encourage all of you, really, when you suspect a child abuse, you have to report this case to the scan team. If you don't have a scan team in your hospital, you should report it to the social service or the hospital administration, because you will be blamed and you will be punished if this child came the next day dead to the emergency and they said, oh, Dr. Fayfi, he saw him yesterday and he sent him home. Okay, you will be taken to the court. So this is a very important. So any infant or young child who present with a history that is not consistent with the presenting sign and symptoms should be considered as shaken baby syndrome. The presence of new adult in the family, for example, this is not his mother, this is the wife of the father, his mother was divorced, or this is like a housemate, or this is a new, so you have to consider all these things also. The presence of a new adult in the home, a history of delay in seeking medical attention. You notice that the child, he has so many problems, bruises everywhere, and you told the family, why you didn't bring him long time ago? Well, you know, we feel he will be better. You have to report this case. A previous history of suspicion of abuse, the absence of primary caregiver, the real mother or the real father, he's not around, okay, at the onset of the injury. Physical evidence of multiple injuries at varying stages of healing, unexplained changes in the neurological status, unexplained shock, or a cardiovascular collapse. So this is a very important that we shouldn't miss. Okay, so how to manage these cases? You have to apply the ATLS guideline, like a severe head injury or whatever, you know, A, B, C, D, E, and look for other associated injury. You have to do, you know, take off all his clothes. You have to be and protect him from hypothermia, and to examine him thoroughly to make sure that there is nothing. Okay. Ask for head CT and C-spine CT, skeletal survey, ophthalmology, assessment, liver and pancreatic enzyme, urine analysis, complete blood or serum and serum electrolyte. This is very important. If you suspect child abuse, then call security and the child protection team. As I told you, security must call police. Okay, and we don't have to reach this stage. We have to call the social service, and they know if they don't have a scan team in the hospital. Okay, and they know what they should do. Admit the child. Most of the time, cases with the child abuse, even if it is minor injury, we usually, if we are strongly suspecting abuse, we usually admit these cases. Okay. Admit the child with one-to-one nursing care and strict security measures. Okay. By the way, those who are writing their name, Hadir, that means they didn't attend with us yesterday, because we said you don't have to write your names, you don't have to write anything except discussing the cases. Because once you are in, once you hear my voice, that means you are automatically present, and you will be recorded present. Okay يا فوزية أنت ومشيرة والجماعة الثانيين، الله يعطيكم العافية. طيب, let's continue. So at the end, remember that shaken baby syndrome is not only a crime, it is a preventable public health problems. Okay, this is very important. You are saving life of patient by reporting these cases. The emergency physician can help to prevent by asking parent how they are coping and with the parenthood and their feeling of stress. talk with them about the steps that they should take at home. And, you know, it needs more of work, actually. That's why we are admitting these cases to the hospital. This is just a reference. Okay, how to. Any question, please, before we go to next topics? For head injury. If you have any question or anything, you can ask now, please. Okay, so I'm gonna go to my next topic, which I think it is very important. Because it is really a very common presentation. Shaken baby, it's a hemorrhage where it depends, you know, if they are shaking their heads and struggling their heads most of the time, it will be in the brain. That's why, yes, we do CT brain. Okay. I need to go to the next, and I think, I hope that we have a good number of participants. Yeah, we have good. And excellent. So as you know, most of you are aware that most of the cases, most of the cases coming to the emergency department, respiratory, flu-like symptoms or cough or whatever. And most common cases that we usually see in the emergency department, and I think we should talk about is and concentrate on, and the management is controversy, is asthma, bronchiolitis, and croup. Okay, because different people, they have a different approach. Before I start talking about these topics, and I think it is very important, I'm going to talk about the practical things, because I know you can read about asthma in any book, or bronchiolitis, or croup, or through online. But there is some practical things that you have to be aware of that may help you a lot when you are managing these cases. And and if you have any question regarding while I'm talking, you can put your questions. Okay. There is a study done by one of our speakers, Dr. Jane Knapp, who presented in our conference in 2012. And she did this study. It is a huge study. Like she collected all the data for patient age group from 1 to 19 years of age with moderate to severe asthma, and for those 3 months to 2 years with bronchiolitis, and for those 3 months to 3 years with croup. Because this is the age group, you know, for croup, 3 months to 3 years, for bronchiolitis, 3 months to 2 years, for asthma, 1 year to 19 years. This was in 2005, and she collected all these data. She got more than almost 500,000 cases, okay? And she analyzed the management of the ER physician there in USA, and she analyzed this data. And what did she discover? Okay, let us see how our colleagues in USA managing this patient, which is moderate severe asthma, bronchiolitis, and croup. Simply just, okay? Yes, here. Let me ask question here now, and I need you quickly, please, to write the answer. For corticosteroid, patient with moderate to severe asthma, would you give steroid or no? Please, yes or no? Patient with moderate to severe asthma, You give steroid or not? Yes, excellent. طيب. Patient with croup, you give steroid or not? Mild, moderate, severe, whatever type. No, 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 no. Yes, 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 yes. Okay. If severe, they said yes or no. طيب, okay, we'll come to that. طيب, antibiotics. You will give patient with bronchiolitis and antibiotics? Yes or no? No, 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 no. Some of you said yes. Okay. طيب. X-rays. Would you do X-ray for bronchiolitis patient? Yes or no? No, no, no. Okay, some say yes. We are talking about clinical straightforward bronchiolitis. Okay. طيب, what about croup? Would you do X-ray for croupy patient? Straightforward? No, 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 no. Excellent, excellent, excellent. طيب, let's see our colleagues. خلاص, enough. No need to answer anymore. Let us see our colleague, how do they manage their patient? You see, 70%, almost 70% of 400,000 patients visit with moderate to severe only receive corticosteroid. What does that mean? That means there is almost 30% they didn't receive a proper treatment. Yes, because they are moderate to severe, they should receive steroid. So they didn't give it. So this is maltreatment, or they didn't give enough. 31% of 317,000 cases of croup, they only receive corticosteroid. Like 70% they didn't give. Oh my goodness. And by the way, just for the sake of time, any patient with croup, regardless, mild, moderate, severe, he should receive steroid. Because mild cases, if you didn't give them, they will come back later in 12 hours with severe croup. So croup, take it from me. Now it is recommended, it is evidence-based that they should receive dexamethasone or steroid, okay, all the patients. So this number, 31, should be 100%, okay? And also 69 should be 100%. I hope this is clear. For antibiotics, bronchiolitis, we shouldn't give antibiotics to bronchiolitis patient unless we are suspecting pneumonia. So this is half of the emergency physician in USA, they are given antibiotics, which is a wrong practice. Okay. Like, what about X-ray? 72% of patient of 72% of patients with bronchiolitis in USA, they are doing X-ray. This is wrong. In bronchiolitis, we shouldn't do X-ray. Please remember it very clearly. Bronchiolitis, it is a clinical diagnosis, and asthma, it is a clinical diagnosis. Croup is a clinical diagnosis. We shouldn't do X-ray for them. It is waste of money, waste of time, okay, and effort. That's why our patients, they keep accumulating in the emergency department, and this causes overcrowding, as Dr. Shehri mentioned yesterday. So that means we are managing our patient better than people in USA, alhamdulillah. Okay, that's very good. You have to be proud of yourself. Good. Let's go to, so what is her conclusion, Professor Nab? Okay, she said, physician treating children with asthma, bronchiolitis, croup in USA emergency department are underusing non-effective treatment. Like what? Like steroid and asthma and bronchiolitis, and overusing ineffective or unproven therapies and diagnostic tests. So they are using something not necessarily, okay, like given antibiotics or given something that shouldn't be given. Okay. Let's start now with our first case, okay? Patient 4 years old girl present to the emergency with shortness of breath, which getting worse with time. She is on Ventonin according to her mother, and she has a history of previous ICU admission, and she looked distressed, and her saturation when she arrived to the emergency, 88, and she has wheezes. What do you think wrong with this lady, with this girl? And she is using her accessory muscles. What's wrong with her? What's your diagnosis? Okay, respiratory distress, we know, yes. Okay, Yes, somebody asthma exacerbation. Excellent, excellent. So let's continue. So what is the differential diagnosis? If you are seeing this patient for the first time, yes, I agree. This is bronchial asthma, but let's say this is the first time you are seeing this patient, and she is not 4 years, she is 1 year of age, and she presented with shortness of breath. And you have to consider differential diagnosis, bronchiolitis. That's why the younger the age, the more will go to bronchiolitis rather than asthma. Foreign body aspiration, the history will help me. Gastroesophageal reflux, the history will help also. Cystic fibrosis, chronic lung disease, like she was already graduated from the NICU or whatever. Congestive heart failure, sometimes they presented with wheezy chest. Anaphylaxis, okay, this is also can be considered one of the differential diagnoses. This is very interesting picture. I would like to show it to you because this is, I think, very important. Most of our children, when they come to the emergency, we notice they are in distress. Very important question you should ask, okay? As someone mentioned here, Doreen, that they're a second-hand smoker. They are a passive smoker, truly, yes. And they will have this kind of respiratory disease, flu-like symptoms, okay? And it's proven by studies that no matter how you treat asthma, if one member in the family, the father or the mother, are smoker, okay, the asthma management will be difficult, and the risk also, okay, will be high. For this patient, 4 years old, I think bronchiolitis is unlikely, okay, unlikely. There is nothing said 100%, but it's unlikely, yes. That's why we said it is asthmatic patient. So I think as a resident or as a fellow or whatever, you are in exam, smoking history, when you are facing a case of respiratory disease, you should ask for smoking history, because you may fail if you didn't ask, because some patients, they are coming to the emergency, given a good treatment, they went home and they come back the next day, and even the father, when he is talking, you can smell nicotine coming from his mouth, and that's why his child is keep coming. And it is part of our treatment is educating the society and telling them that you should you should quit smoking, or at least smoke outside the house or whatever, because this is one of the important factors that trigger asthma attack and causing difficulty in managing asthma or other respiratory disease. Okay. So now this is most likely, we said this is an asthma. And what is the pulmonary index score? How you assess asthma score? Is it mild or moderate or severe? There is so many ways you can assess, okay? But either wheezing or the IE ratio, or use of accessory muscles, or this is when the attendance, when they present in the emergency department. So our patient, his saturation is 88. As you can see, we score very high score here, less than 93. So this patient, he has a severe asthma attack. That's why you have to be aggressive managing these cases. Most of our asthmatic patients, when they present to the emergency, most of the time, their saturation around 95, 94, 92, more than 92. But if you have a child less than 90, this is an alarm. And usually these patients end up by admission. Okay, and this is like an evidence based on the study. They did a study on patients with saturation less than 90. They are highly, the high predictor of being admitted to the hospital. Usually we are using this index score most of the time in research purposes, but we don't use it in emergency, but it can give you a hint in emergency department. Okay. Yes, pulse oxy is very important, and now we consider it one of the vital signs. Okay, it is non-invasive and it's very important. And you have to provide oxygen whenever his saturation is less than 92, or even if his saturation is 96, 95. But you notice that the child, he's working very hard. he's having raising LNSI and he is in distress. Give oxygen, because the oxygen, it is a drug, it's a medicine. It causes bronchodilator, it helps in asthma, okay? And also, it may reduce the work of breathing. So you don't have to, because, you know, sometimes some of your nurses, they are very careful for the patient. And when you ask her, please give oxygen, but doctor, he doesn't need it because his saturation is 95, 96. No, you have to tell her, no, you should give it because he's working hard, he's in distress. By giving oxygen, this will reduce the load, the work of breathing or the load of breathing. Okay. Do we have to do X-ray, as we mentioned? No, we shouldn't do X-ray. And usually this is the finding of X-ray: hyperinflation and flat diaphragm. So this is what, so it is a waste of time and money, but also it is very bad for the patient. Just imagine a child who's coming every week or every month to the emergency, and you keep doing X-rays every time he presents in the emergency. Somebody will ask, doctor, give me an evidence why you shouldn't do X-ray. We'll show him this one. This is an old study, more than almost 30 years ago. But still people, they take it as an evidence. When should I do X-ray for asthmatic children? Okay, this is almost like 400 child. They present to the emergency with the first time wheezing, okay? And they did for them, all of them, they did an X-ray for them. And they discovered that 94% normal X-ray. And they took the 6%, which around 20 patients, okay? And they analyzed their data and they discovered their respiratory rate more than 60. As you know that this patient more than 1 year of age, okay? And more than 1 year of age, his respiratory rate around 20 to 30. So if his respiratory rate more than 60, this is like a neonate rate, which is even tachypnic for, considered tachypnea for neonate. So it is significant. Heart rate more than 160, it's the normal for 1 year age, it's around 100. Fever, high fever, okay, or focal finding. So you should, in these cases, and based, and this is Grishel, he recommend and he advised that if you have a child who's presenting with significant wheeze and he has like severe disease, like his respiratory rate or the heart rate or high fever or focal finding, then you should consider X-ray for this patient, okay? That's why someone here said in pneumonia, to exclude pneumonia, yes, but not in every patient coming to the emergency will do X-ray to exclude pneumonia. Also for pneumonia, it's a clinical diagnosis. If there is a crepitation, if there is a decreased airentry, why you have to do an X-ray? Give him a treatment for pneumonia. Okay. Especially if you are thinking a straightforward pneumonia. So, so this is the indication: focal finding, fever, or severe disease that he's not responding to the usual treatment. For example, we give him Ventonin back to back, and we give steroid, we give everything, but the patient, he's still not improving, and you are suspecting something else, something significant. Then you may consider doing a chest X-ray, okay? What is the treatment for option for asthma? I don't want to talk about it because I know most of you are aware. It is Ventonin, okay? Steroid, and now we advise to give Atrovent, which is ipratropium bromide with the Ventonin, and magnesium sulfate should be considered, okay? There is an important question. I'm going to talk about in the next few minutes also about this. And please, concentrate with me because this is, I think, very important and most of you are not aware. Which you prefer to give, nebulizer or puffs? MDI or SNV? Puffs, neb. Okay, there is a confusion. So some people, they said buffs, and some people, they said nebulizer. Those who said buffs, I think you are right. Those who said nebulizer, you are right sometimes, not always. Okay, so that's why buffs, it's recommended now everywhere. In the past, I remember when we used to be in Canada, most of the emergency department, or in North America, they are using nebulizer in the emergency department. But in United Kingdom, in England, and most of the European countries, they are using buffs in the emergency department. Okay. Recently, in the last 10 years, the North America, they changed their behavior, and they start giving buffs, and they believe it is much better than nebulizer. Most of the study, by the way, we reviewed more than 10 studies, like there is so many meta-analysis, and it indicates there is no difference between nebulizer and buffs. But why we are preferring buffs? Buffs because it is easy to use, okay? And it is handy, and it is portable. You can use it everywhere. You can take it to the school, to the mall, to the desert, to everywhere, okay? And once the child learn how to use it, it will be easy to, and it will be good. And he knows whenever he needs it, he can go and take it. Nebulizer, you have to have, like, you know, a machine. You have to have a nebulizer. I know there is a new machines in the now in the there is new equipment that very handy, easy, but still buffs, we consider it easy to be given and much better to be given. And I hope from this lecture try to encourage using buffs even in a very young age group. Okay, I know some of you will say, but doctor, the patient will respond to nebulizer more than buffs. This is not true. If you are giving buffs in the right time and the right number, how many buffs, and the right frequency, you will see the difference. It will be much better. Okay, this is my advice. And also, if you remember, if you give nebulizer, children, they have tremor and they have palpitation more than those who received buffs. And as you know, buffs usually, each buff, how much? Each buff is 100 microgram. And when you give nebulizer, the small dose, which is 2.5 milligram, which is 0.5 cc, it is how many buffs there in half a cc? You remember, you know, how many buffs in 0.5 cc of Ventonin nebulizer? 2 to 4 buffs, 2.5 milligram, you're right. So 2.5 milligram. So how many buffs in 2.5 milligram? If you calculate it, yes, each buff is 100 microgram, okay? And 2.5 buffs, that means 25 buffs. Excellent. Yes, 25 buffs in each one nebulizer. That's why when we advise to give the medication, how frequent we should advise to give buffs to patient as an outpatient. For example, you have a patient in the emergency, you treat him, you give him Ventonin back to back, and now you want to send him home. How many buffs you should give? And how frequent? 2 buffs. Minimum Q3 hours, 4 to 6 according to age, 2 to 4 buffs. If need more than, should retain 2 to 4 buffs. Oh my goodness, 4 to 6 buffs, 4 buffs, 2 to 4 buffs first day, 4 to 6 buffs. Okay, you see, this is why I think this is a very important. Oh, Abdullah Al-Mutayri, he said 6 to 12 buffs. I like his answer, as needed. This is a diplomatic answer. Okay, let me tell you, we don't want to waste time. According to GINA guidelines, this is the global international, this is what we are following, okay? Not in the emergency, as an outpatient, and even in the emergency. Yes, now we should encourage, but I know we will find some resistance in the emergency for using buffs in the emergency department because you have more nursing staff, okay? Or we need more like asthma educator in the emergency department, okay? We should give, according to GINA guidelines, 4 to 8 buffs. Every how long? Every 2 hours to 4 hours. Someone will say, oh my goodness, this is a huge. No, this is not a huge. We notice, and based on the study, that children, they don't know how to inhale. You know, most of the time they are closing their mouth. Okay? We should give it every 2 to 4 hours. Okay? And then we should encourage the mother or the caregiver to space it according to the response of the child. If he's getting better, then you can make it 4 hours or 3 hours, then 6 hours, then 8 hours, then 12 hours. So you are the one who's treating your child. We tell the mother, you are, you know, in North America, let me tell you, some of you said he keeps talking North America. Yes, North America, we never see asthmatic patient coming to the emergency because the parents, the mother, she is the one who's treating her child there. Unless for those who are refugees or those who are homeless or those who are coming, you know, from the street, they need some treatment. But the rest of the people, the mother, she is treating her child there. You don't have to wait for your child till he start coughing badly, because at this stage, you have to start a steroid. Okay? I know there is some resistance from the family, but still, it is your job to show them. You know, most of the time when I talk to the family, they told me, doctor, you are the only one who's talking like this. Nobody tell us about this. And we know the society here, they are panic of Ventoline. Oh, بيدمن على الفنتولين. He will addict Ventoline. This is not true. Okay? And we'll tell her, Ventoline, it is a very benign, it is a very safe drug. Okay? And you have, you know, they did a study on adult. And they are doing, they are taking mouthpiece and inhaler. And you know how much they find in their lungs, Ventoline deposit? Around 10-15%. Okay? Okay. And what they find, these 10 find, what did they find? They found that it's open. What did they find? They find that less than 15% in adult under the best circumstances. Okay, so what about children? I'm sure that children less than 5%. This is why we should give more Ventoline as a buffer, as buffs, not as a nebulizer. Okay, and the family, if you tell them about this, they will appreciate, they will understand, and they will realize, and then they will do whatever you ask them to do. Okay, so this is a very important. So my advice, I won't spend too much time on this. We will give usually in the emergency department Ventoline with Atrovent for younger age group, you know, 2.5 milligram with 250 Atrovent, okay, 3 back to back. And the steroid should be given as early as possible. And after that, for 1 hour, if they didn't respond, this is an emergency treatment. If they didn't respond, I should consider magnesium sulfate. Magnesium sulfate is a very safe drug. So you don't feel scared of using magnesium sulfate. Is this way we can give it like this? No, we shouldn't. This is, nothing will go to the lung. But this mode of delivery, you can use it in what case? In which cases? To save time in croup, okay? In croup, because you don't like to irritate the child to make him cry. Excellent, Sharif. Okay, this is very nice. So, okay, this is the way we encourage our children to take nebulizer, okay? This because it will go to the lung. This is one of the ways that we should encourage. Usually children more than 4 or 5 years of age, they are very cooperative. They feel like lightheaded, but you can tell them once you take 2-3 inhalation, if you feel drowsy, you can stop and then re-inhale again, okay? This is the way of using the air chamber, you know, different air chamber. I try to encourage this one, you know, with the mouthpiece, especially for older children. Okay, this is very important. As I said, Atrovent is now recommended for in the first 3 doses, all the doses you can give. Air chamber, the way you can go. This is the air chamber with the mouthpiece. I think we should encourage it because I think this is an adult. They are using it, and in older children. Some of our children, we are giving them if they are cooperative and the mother can teach them, like you can see in the picture. What about steroid? Steroid should be given as early as possible in moderate to severe asthma. Okay, that's very good. What about disposition? As I told you, the most important is education, education, education. No problem. Okay. Okay. And please, this is an important message. Just in the next 1 minute, I have to tell you, you can instruct, give the mother puffs, for example, Ventoline puffs with air chamber, either mouthpiece or face mask, and tell her, please, you don't have to wait till your child keep coughing, 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 coughing. No, once you notice that there is start to have some runny nose, start sneezing, start coughing, the weather start changing. Okay, he is going to the mall, to the playground. He will do some activities. You know, there is something called exercise-induced asthma. You have to be ahead of the disease. Try to encourage given the Ventoline before, because as you know, asthma it's 2 stages. The first stage, alveolar obstruction. Okay, Ventoline will work in this stage. If you are late, then you have to keep giving a steroid, and this is very bad. So we have to be as early as possible. Okay, ahead ahead of the disease. This is what I encourage all my patients to do so. Okay, in case of if he didn't respond, as I told you, then you had to consider magnesium sulfate. I don't want to go because if he didn't even respond, magnesium sulfate, some people of you, they are scared of magnesium sulfate. And to be honest with you, I have a nice, yes, this one. Is it safe? It is very safe. Okay. And the dose usually 50 to 75 milligram per kilogram per dose. And usually you give it over 20 minutes. Okay. And also it should be given, as I told you, over 20 minutes. And you don't have to be scared of any complication like hypotension, cardiac conduction disturbances. What is the level of magnesium in the blood? Usually it's up to 1.6, okay, to up to 1, okay? So whenever we give, based on the calculation and based on the calculation, when we give this 75 per kg, the level will never reach more than 3. And usually hypotension and arrhythmias will not occur unless the magnesium level is more than 8. So guys, please feel free to give magnesium sulfate. طيب. Case number 2, because I think I'm running out of time. This is a, do you have any question in asthma management? Usually ipratropium bromide, which is the Atrovent, is given in the first 3 doses. But some people, they use it more. But the efficacy is more potent in the first 3 doses in the emergency. If we are using IV methylprednisolone, why we are still use inhaled Pulmicort? Still, yes. We don't use IV methylprednisolone. By the way, steroid, we give it oral. The IV versus oral is the same. The outcome, everything. Please don't give any IV anymore in asthma or in croup even. This is very important. Okay. Well, some people, they prefer, our public, our population, our society, they don't like the word asthma. That's why I encourage my resident not to say asthma to them. Tell them he عنده حساسية, he has some allergy, hyperreactive airway disease. This is the way. It is the same meaning. Okay, let's go to the next case, please. 5 months old, present with cough for 2 days, preceded by upper respiratory tract infection. His feeding has decreased and his cough interrupts sleep. Temperature 38 at home. Normal physical examination. Okay. Broncholitis, excellent. You made my day. Thank you very much, Abrar. So this is broncholitis. How you will manage broncholitis? Okay. Mhm. Suppository? No, there is nothing called it. Oxygen, excellent. Oxygen, supportive, yes, you are right. Oxygen, okay, and IV fluid. So this is the two indication. This is a common question in the board or in the residency program when you consider admitting patients with bronchiolitis in two conditions, okay? One is when he is hypoxic, you cannot send the patient home with hypoxia, or poor oral intake. He has a significant respiratory distress that made him have that made him not able to take oral or tolerate oral intake. So this is the two indication. Do we have to do nasopharyngeal aspirate to diagnose bronchiolitis? No, this is a clinical diagnosis. Excellent. This is a clinical diagnosis. But sometimes we have to do it when we decide to admit them, because we need to put them in one room, you know, all bronchiolitis RSV patients in one room. Okay, but if you are not admitting them, there is no need to do any diagnostic test. Okay, طيب. If you have a child who's like 2 months, 3 months with fever and bronchiolitis picture, typical bronchiolitis picture, someone will come and tell you, doctor, we have to do CBC differential rule out sepsis. According to the American Academy of Pediatric and the guidelines, you don't have to do any blood work, anything except urine, because there is some association with urine infection with bronchiolitis patient. Okay. Otherwise, if it is a typical bronchiolitis, the fever usually secondary to bronchiolitis, so it is not secondary to serious bacterial infection. So there is no need, okay, for febrile infant with confirmed viral infection like bronchiolitis to do any labs for them. Only, as I told you, urine DEB or urine analysis. Okay, differential diagnosis, as if you, all of you aware. Okay, do we have to do an X-ray for this patient? No. Excellent. Excellent. Because the finding is the same. And you can see there is a prehilar lymph node in the left side. This is always finding in asthmatic and bronchiolitis patient. Even if he is, for Marwa, even if he is less than 3 months, if he presented with typical bronchiolitis picture, you don't have to do any blood work for him. Okay? Just only do a urine test. Just to make, if turned to be UTI, then this is considered serious bacterial infection. Then I have to do blood work. But less than 3 months with typical presentation of bronchiolitis, go ahead and manage him as a bronchiolitis patient. Okay, and do urine dip only, no blood work, nothing, and the mother will be happy and grateful and thankful to you. Okay, evaluation. Do we have to do an X-ray? This is a study to prove that there is no need. Okay, the finding were consistent, so there is no need to do an X-ray. Please, this is very important. That's why when I like attend any take an endorsement or anything, and somebody, we have a patient with bronchiolitis and X-ray showed normal finding, I said, why you did X-ray? So this is bad. You shouldn't do it. Okay. And here for bronchiolitis, history and physical, this is the American Academy of Pediatrics subcommittee for bronchiolitis. So it mentioned that history physical examination is the only the basis for diagnosis of the disease and severity assessment. Lab and radiological studies should not be ordered routinely unless the patient, he is deteriorating. Okay, and you are suspecting something else, for example, like heart failure, pneumothorax, something serious going on, then you may do X-ray. Okay, what is the high risk of patient with the bronchiolitis? Very important, the very young age group, like someone, bronchiolitis in one with 16 months, 18 months old, compared to 1 month with bronchiolitis is totally, so 1 month, the younger age group is a high risk. Okay, and you be aggressive in managing this patient, or premature also, or there is a history underlying disease like cardiac patient or chronic lung disease or bronchopulmonary dysplasia or cystic fibrosis, or if there is any history of apneic attacks. So this is also a significant high risk group. What is the treatment? As we mentioned, treatment, it is supportive, as somebody mentioned here. Just suctioning, if there is any secretion, you don't, and this is an advice, please, for our colleagues, our nurses, our lovely nurses, don't do deep suctioning, only because usually most of the children, they swallow their secretion. But if there is a lot of secretion around the mouth and you can see there is oral secretion coming out, just quickly do it, okay? Because the more you keep the suction in, the risk of apnea and gag reflex will be there, okay? After suctioning, also Ventoline considered to be one of the treatment, okay? As you can see, they did so many studies, but there is no difference in clinical finding, Ventoline or, but still, there is some group, they may respond to Ventoline. And I believe those group who has a history of asthma in the family, so that's why they respond. And Ventoline is a very, very benign medication, so you can give Ventoline. If they respond well, so then you can continue Ventoline. If they didn't respond, okay, and they got sick and they are hypoxic, so you have to consider other option. For example, like what? Like Ebeneferen. Okay, Ebeneferen, it's proven to be effective in some cases also. Hypertonic saline, it's proven to be not effective. However, there is some people, for example, in military hospital, in some areas, they are using hypertonic saline, okay? And if it is proven to be effective, you can use it. It depends on your preference, okay? What else? Okay. Ipratropium bromide, Atrovent, is it proved to be effective? No. That's why we shouldn't use it only in asthma medication. What about steroid? Shall we use it or not? Yes, yes. No, it is wrong. We shouldn't use a steroid in bronchiolitis. I know some people, they use it, and there is some studies, they use it, but still, it is not widely used, okay? Not proven effective, absolutely. And you didn't know, after 10 years, maybe it will prove to be effective, especially in those of allergic type of bronchiolitis. I know it is viral, but some of these children, they have strong family history of asthma, they have eczema, so they may benefit from steroid. Important question. Marwa asked, which is better to give Ventoline or Ebeneferen? First, you should try the easy one, Ventoline. If the patient did not respond, then you can use Ebeneferen. I noticed some people, they are practicing giving Ebeneferen first, which is wrong. You shouldn't give Ebeneferen first. Give the widely used medication, and most of the children, sometimes they respond to it. If he respond or she respond to it, then you can continue. If he didn't respond, then you can use Ebeneferen. I hope I answer your question. So management of bronchitis should not routinely given like Ventoline. It shouldn't be. You know how many percentage coming? Bronchiolitis is very common disease. It's very common. Okay, 90% of children by 1 year of age, they have bronchiolitis. 90%. My goodness. And 100% by 2 years. And those who are coming to the emergency, only 10% of those who has bronchiolitis. The 90% of the 100% who has bronchiolitis, they stay at home because it is very mild. Bronchiolitis is a mild. 10% they come to the emergency. 1% of those coming to the emergency, they may need ICU. That's why it's a very common disease. And now they are trying to get vaccine for it, and several trials, but they didn't manage to reach a vaccine. Hopefully soon they will have. Okay? Yes, especially nowadays. You are right. Today, these days, we have a lot of bronchiolitis. So this is why, guys, No need to do x-rays, no need to do blood work, no need to do a lot of things. Okay, just give Ventoline. If he improved, fair enough, suctioning and discharge home. If his saturation is okay, his intake is acceptable, send home. Don't accumulate patient in emergency department. And the use of inhaled bronchodilator should be continued only if positive clinical response. This is true. The use of bronchodilator or epinephrine is an option. Yes, it's true. The management of bronchitis should not include the use of a steroid, as I mentioned. Okay, this is the American Academy of Pediatric recommendation. Right. Case number 3, the last case. I have only 5 minutes. Hopefully I can finish. 3-year-old with cough at 2 a.m. Any question regarding the asthma, bronchiolitis? You can write it and I will answer it while we are doing this next case. 3-year-old with cough at 2 a.m. The child had upper respiratory infection for 2 days and then began to... Lisa, I think you saw my slides. Okay, and Dareen. Okay, so this is a group. Okay, you made it easy for me. Thank you very much. Do we have to steroid and home? Excellent. Excellent. All right. So do we have to do chest x-ray? Yes or no? Lisa, Karen? No. Excellent. No. Big no. Thank you very much. طيب. What is the treatment option? Mist therapy. It's not proven to be effective. However, some people, they are using it. Corticosteroid. As we mentioned, yes, corticosteroid. Some people, they said they are giving it as an IM. It is not anymore given IM or intravenous. No, give it oral. Unless you have a child who's refusing to take oral, okay, or has frequent vomiting and he's not keeping anything in his tummy, then you are forced. You have no choice to give IM. And the dose usually 0.6 milligram. This is the standard dose. 0.6 milligram, okay, and per kg, and the maximum dose usually 12 to 14. I remember one patient we had, his weight is around like 40, and the resident gave him like around, decide to give him 30 milligram. No, be careful. The maximum dose for dexamethasone is 14 milligram. Thank you very much. Racemic Ebeneferen should be considered, very important. When there is a stridor. If you have a stridor at rest, inspiratory, expiratory, you should consider it. If you have, even if he's screaming, if you think, if you are afraid, racemic Ebeneferen is very safe drug and we give it as an inhalation. And as you know, yani, this is an upper airway obstruction, so it's very important. Okay. This is the way. Sometimes if we have a difficult child, you can give it this way. Okay. Some of our nurses, they are doing this. This is an excellent way to deliver because it is an upper airway obstruction. So we needed to, but for asthma, no, I should use the mask. Don't use this way for asthma children or bronchiolitis, because for asthma and bronchiolitis, we need the Ventoline or the medicine to reach the alveoli. Okay. Question, when it's given oral, when it will start within 2 hours when you give it oral. Okay. So there is no problem. Give it oral and don't worry. Okay. This is just the algorithm, a brief of what I have said to you. Okay. Excellent, Lisa. Okay, any question? Steroid, as we mentioned, should be given to every patient with croup, even if it is mild, very mild croup. Give it, please. Mild, moderate, severe. Any question, please? For asthma, bronchiolitis, croup. For asthma, please, I hope that you got my message very clear. We can manage our children very well outside the hospital without forcing them to come to the emergency. It is part of our mistake, because I know sometimes by mistake, somebody will write, give Ventoline 2 puffs every 4 to 6 hours. This is very bad. 2 puffs, and you know, they don't inhale very well. They don't know how to use. Give 4 to 8 puffs every 2 hours. One mother, she called me and she said, my child, he's in asthma, severe attack. I told her, what time you give it? She said, as you prescribed 4 hours ago. I said, I never prescribe it. Like, you're calling, I don't know. I told her, okay, keep giving Ventonin till you reach the emergency. She said, are you crazy? I said, no, just give it, please. The patient, she keeps giving, even if it is 100 buffs. I said, even if it is 1,000 buffs. So please encourage our children to, because they don't know how to inhale. Minimal amount of Ventoline will reach the lung. Any question, please? Croup in asthma patient. Yes, it will be nice. Croup in asthma patient, the management will be the same. You give him dexamethasone right away, and then you start the asthma management. Can we give nebulizer and asthma management? Yes, of course you can. You can. Sometimes when you have asthmatic child who has a silent chest, there is nothing, he cannot breathe, then you are forced to give, you know, systemic. You treat him like anaphylactic shock. You give him sub-Q Ebeneferen. Okay. At the same time, you keep giving the nebulizer. Okay. Okay. Any other question, please? This is by Twitter. If anybody has any question, I'm more than happy to answer. And I hope you are happy. This is our conference. We already received an approval from the American Academy of Pediatrics. Okay, they are coming in March 22 to 24. This is even they accredit our conference by their hours, American Academy of Pediatric and American Academy of CME hours and Saudi Council. So I really encourage all of you to attend. They are coming from the American Academy. They are well-known speakers, excellent speakers, and you will enjoy, I promise you. So please attend and take a shot of this slide so you can register. Thank you very much. And now our next speaker is Dr. Salih Al-Shehri. I hope he is around. Excellent. I finished on time. Okay. Thank you, everyone. Most welcome. Let me get out of this so Salih, he can. Start. Khulud, if you don't mind, please, can you put the schedule of today on the screen so everyone will be aware of his of the lectures? And now Dr. Saleh will start now. Okay, his presentation. طبعا Dr. Saleh will talk about approach to febrile child. It is a very important topic. And also he will talk about cardiac emergencies. And then Dr. Our nursing instructor Hussein Al-Hababa will start, and Dr. Hamad Al-Madi will be with you afternoon, inshallah. So Dr. Saleh, you can start. Thank you very much.
السلام عليكم. السلايد واضحة والصوت واضح دكتور محمد؟
Yes, very clear. You can start, Dr. Saleh, please.
like that. طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا وحبيبنا محمد عليه أفضل الصلاة والتسليم. I'm going to speak in this lectures about how the approach to the febrile child or child with fever. I'm not going to speak about specifically about the diseases or how can we start appropriate antibiotic. We'll talk here in this lecture how to approach the febrile child who present to the emergency and how can we talk to the family there and how to approach to the family. Bismillah ar-Rahman ar-Rahim. The main point I'm going to discuss it here is to describe fever and the febrile response here. Discuss the common myths اللي بتحصل دائما في emergency. We think about it, والphobias from emergency from the family. Review the standards for fever assessment and the management, and identify the concern related to the gastroenteritis, vomiting, diarrhea, underlying illness, and seasonal epidemiology. Also, we review the use of antibiotic, and is it enough to use Fivadol or ibuprofen or both alternative? Is it going to be helpful by themselves or going to be adding antibiotic for that? That's where we see it in the next few slides, inshallah. Fever. Fever is the most recognizable symptoms of any illness. The most concern for, sorry, if you can stop the using of mouse, please. Okay. Fever is the most recognizable symptoms of any illness. Is the most recognized concerns here for parents in between the vital signs. Parents here will make lots of effort before they reach to the emergency. So keep in your mind the child before came to the emergency. They already made a lot of measurements and giving a lot of sometimes of Fifadols. Some of the parents really scare me when they tell me that my child, they give him Fifadol every 2 hours. And the fever, I cannot control it. You can treat it, but you cannot control it. Sometimes it's like bacterial infections. You can give some treatment, but unfortunately, especially in the first 48 hours, first 2 days or 3 days, sometimes the fever is difficult. It's nature of the fever. It's very difficult to control it. Parents also be having worries and fears. Also, the physicians having worries and fears about dangerous fever in emergency area. Epidemiology here, it's 15 to 30% of all ER visits is because of the fever, and there's seasonal variation. In the winter time, it may be up to 60% of all ER visit in some center. Kids less than 2 years may have 4 to 6 times fever per year, and actually there's some studies mentioning the child in the school age, they may have 12 times, not 1 or 2 times at episodes of fever per 1 year. This is not related to his immunity. Immunity is good. This is because if he's exposing to variety of virus infection there, and the child will be looks well in between of these illnesses. 20% of the fever are fever without source of infection. So keep in your mind that's out of 10 patients present to your emergency, you may have 2 child. There is no source for the infections, but there is maybe symptoms like sneezing or cough, but you will not have a clear source for that. 1.6% of all ED visit, they are between 3 months and 3 years. Their temperature is more than 39 and they don't like toxic. More than 50% who present in off hours of clinics. That's why don't be feeling frustrated that you have a lot of patients after 11 o'clock p.m. because the parents, they cannot sleep once the child looks febrile. So they will ask for medical help because they are worrying about maybe the child, he will die during sleep, or he will be burned, or he will be cooked, or he will lose his brain. That's why many parents, they come after off hours of primary healthcare. After they close, they will come to the emergency because they are seeking how to control their fever. And most of the time they came to the emergency, they look panic or anxious, or they want urgent help. How can we solve it? Some of the parents, they will ask for admissions. Actually, there's some parents, they ask for admission in ICU because their child's temperature is 39 or 40. Fever is the most common complaints here below 6 months. It's the most common attractive diagnosis coming to the emergency because of the fever. Most of the fever they present to the emergency below 6 months is between 38 and 38.5. And most of the cases, they look non-toxic. Okay. Here, in general, how's our body, subhanAllah, can control the temperatures or regulating the temperature inside the body? It's many factors there. It's been from the physals, also from the even from the WBC will participate in the controlling of the temperatures. This is using of involuntary movement, muscles or shivering in the body. Also, the thyroid will increase the metabolic rate in the to the cells. They will send a message to increase the metabolic, so they will increase the temperatures. And hypothalamus, this is actually the thermostat for the whole body, who's going to receive all the signals from blood, from WBC leukocytes, from the thyroid message, from the infections, to increase the temperature according to what's the body they want, like the temperature to go up 38, 38.5, 40. This is the hypothalamus will control all these things. So the thermoregulatory here system, the hypothalamus here, subhanAllah, is the center for that. It's the thermostat for the whole body, and that's controlling everything for the temperatures. But he needs to receive input and signals from the other part of body to regulating these temperatures. He will receive from peripheral receptor, from blood temperatures around the hypothalamus. He will receive signals from WBC. So the neutrophils will receive the arachidonic acids, which is our wonderful hormones here, will participate to increasing the temperature. Also, we'll know the prostaglandin once been releasing. So that's when they will ask the hypothalamus, please increase the temperature up. Also, acts of autonomic on endocrine, like thyroids and behavioral mechanisms. And then after that, the temperature will start to be going up their temperature. Febrile response here, this is, we have two types of phases here. Actually, we have three phases, but we'll talk about the chill phase. This is sometimes the child who present to the emergency, temperature is 37.5, for example, or there is no fever, but the family, they will feel rushed or anxious once they start to have shivering unnecessarily. And they told us, just we measured it 5 minutes back, it's 37.5. What's going on with my child? Here is the starting of chill phase. That means the temperature will start to be going up. The fever start to be generation. It take sometimes up to from 10 minutes to 30 minutes. Temperature be increased. Here is the body temperatures here is less than new set of thermostat. So the physiological heat change need to be increasing the temperatures and heat generation. What's will go on here to increasing the temperature inside the body here? Increase cell metabolisms. This is by through sending signals from the thyroid. Muscle activity, you will start to rub yourself and start to move to increase your temperatures. Also, there is involuntary shivering. So the body start to shiver until you increasing the temperatures to what's the hypothalamus, you want that temperature to be the set point. There is another things happened here, which is we call it heat conservation. هنا لما بالفاميلي بيجوني يعني call you, my child is getting blue, his hand and lower limbs is getting blue. What can we do here? Actually, this is part of fever response here, and start to have this vasoconstriction to reserve the temperature inside the body. So we make like isolation of the body from outside. The child here, he will go, under the blanket, or he want to prefer to warm, or he will ask the parent, please switch on the air conditions to the heaters, so I feel more warmth, because the child is still having very cold. Enter the body temperatures equal to the new set of the thermostat, and this is the balance. The child doesn't like the body temperature go down. He will say once it's coming down, he will start to have shivering and will start to cover himself by a blanket or ask for heater to open it up again, like that. Another point here. هذا لما الparents they will come to your side and they told us, my child sometimes when he's going to sleep, he's getting red, or his face getting red or pink. We don't know what's going on with him. We are really concerned about this point. This is what we call it as flush face. That's meaning its temperature is coming down. This is the redness here is actually a vasodilation from the body. So the body here will allow the temperature to release the temperature from the body. And instead of vasoconstriction, now this is the opposite side, it's a vasodilation here. This is what we call it resolution to the normal. So the episode of fever or the phase of fever start to be now end. Here is the body temperatures is more than you set thermostat. A child here, he will feel hot. Then gradually the body temperature will go down slowly. Actually, sometimes it takes up to 1 hour to bring it down, the temperature here. The physiological change here to decrease body temperature here by the heat loss is obligate heat loss, vasodilation, and sweating. That's to accelerating the temperature. That's why sometimes the parents, they put some water or they shower the babies once he's getting this face red. So they will take him to the shower. You think he's having this temperature is 40 or 41. And actually, when he's getting blue or hands blues, actually his temperature is coming up, but this face, the temperature is coming down. In this case, and this temperature and these pictures, the child is preferring cold temperatures or cold weathers. This is the face. We have 3 phases here. As a summary for what we mentioned before. This is a chill phase, with meaning the warming phase. Temperature will go up from 37.5 to 39, 38.5, 39, whatever. And then there's a plateau phase, and this will be, the temperature will be stay in this phase, like sometimes take hours, 3, 4, 5, 6 hours, this phase, according to the body response to the infection. And then there is a defervescence phase, which is meaning of cooling. Temperature will coming down gradually. As we mentioned, is this phase maybe taken up to 1 hour to decrease the temperatures gradually. So here's the thermostat in the body. It's hypothalamus. He having a new set of the temperature. So he will bring it from the plateau phase to the cooling the bodies until the temperature reach up to 37.5. So here are the pictures here. The pictures here about the parents and the temperatures. This is some funny. This is about funny study about how their parents they are measuring the temperatures, and Is my sound clear? I think it's already disconnected. Okay, so this is a nice study about the parents and the temperatures. It's how they often the temperature check their child with fever. وجدوا انه 15% of the parents, there is 9% of the parents, they are measuring the temperature every 15 minutes. وفي 20% of the parents, they are measuring the temperature every 30 minutes. 23% of the parents, they are measuring temperatures every 1 hour. So most of the parents here, they are measuring temperature in less than 1 hour. وفي parents 17% they are measured every 2 hours. و 31% of the parents, they are measured more than 2 hours. طيب. And from time to time, I'm looking to the chat, so I'm looking to the any questions or to your notes here. طيب, parents and temperature here. Wake up a child to check the temperature. We found that 85% of the parents, they are wake their child from the sleep just to measure the temperatures. Also, there is a point, fever can damage the brain. When they make questionnaires to the parents, they found it in 21%. So 1/5 of the parents, they're worrying about the damaging of the brain. 14% of the parents, they are worrying about the child, he may die during sleep. So they are scary. Once we are awake from sleep, our child will be dying. They found it in 14%. So this is common behaviors that we may face at an emergency, and we need to deal with it مع البارنتس في emergency. طيب, is high grade fever is associated with high mortality or no? Or it can cause brain damage or death? Can I hear some story from you or yours, please, about the common myths emergency in about the fever? اكيد كلنا شفنا fever في الامرجنسي, بس انه ايش الكومن myths اللي بنسمعها من البارنتس اكثر حاجه؟ Child with convulsions. Yes, هذه common things that child may be convulsed. The patient will be either die or going to seizures. Convulsion 3 times. الحين قاعد اسمع permanent damage. هم بيتكلموا كثير البارنتس عن permanent damage in the brain. Yes. Any also thoughts about this? Okay. So the comments فعلا انه maybe seizing, septic shock maybe from our side. We're worrying about it. We're always worrying about serious bacterial infection. But from the parents, usually the convulsions, brain damage, my child will be burn also. Leukemia, okay. The rigorous convulsion, okay. So we are hearing many stories from the parents there. Leukemia, yes, sometimes I'm here, especially if there's one part of the family having leukemia. So they will bring all the kids together to the hospital, to the emergency, with every episode of fever. Immunocompromised, إذا قالوا إنه الفاميلي إنه is having more frequent having viral infection during the years. So they want to check his immune status. Yes, fever has to be treated with antibiotics. Allah musta'an. Yes, and they are sometimes they are asking strongly for antibiotics. Yes, I agree with this one. طيب. So we can hear here common stories about that. We are agree about most of the families when they bring their child to the emergency, they are worrying about the seizures, about the brain damage, sometimes the cardiac issues because he's tachycardic. What's going on inside it? We need antibiotic to solve this antibiotic. Yeah. So dangerous fever here. Dangerous fever. We should be from our side to be different between fever and hyperthermia. There is a difference between fever and hyperthermia. Fever is it's physiologically things. It will never ever harm the body because the body is the one who is regulating the temperatures up to the point that you need it to facilitate for neutrophils and interleukins to kill cytokines to kill the organism inside the body, but will not be increased to harm the body. So there is a limit for this fever. But here the problems with hyperthermia, no. Hyperthermia can reach up to 42 sometimes, 41.5, because there is a damage or congenital anomaly inside the brain. So fever will raise to set point as a result of triggering from several virogenic cytokines. So there is a triggering for that. Hyperthermia, no. The thermoregulatory system here is either dysfunction or simply overwhelmed by the variety of internal or external factors, like excessive heat productions, damaged heat dissipations, and hypothalamic dysfunction. Actually, the highest temperature that I saw it in my history, that's this child with having CP, his temperature was, I think, 42.2. 42.2. This يمكن هذا أعلى رقم شفته مع الأطفال. Hyperthermia usually it presents not by itself. Usually there's some problem with the child that's cannot control the temperature. There's hypothalamic dysfunctions, or like introducing medications like SUX or something that will be the body will react badly with this medication. Dangerous fever here, no evidence that a child with fever are at risk of serious sequels from physiological fever. على العكس تماما طبعا الهايبرثيرميا لا الهايبرثيرميا can harm the body actually, and that's why when it comes to the emergency we need to control it fast, or لا قدر الله حصلت or happened in operation room, need to be quickly to stop it by doing all the measurement to decrease the temperature. Some kids here with chronic illness is not able to control or tolerate the increasing metabolic demands زي موضوع حقين metabolic disorders أو زي حقين organic acidemia, MMA برضو, they don't control. That's why when they present to the emergency with fever, we need to give them like dextrose D10 because إنه عنده metabolic state is very high and start consuming all the blood sugar inside the body. You need to meet with it. Can parents detect fever subjectively? If I can ask some of you here, أكيد إنه many of you they having kids. So are you using the hands to measure the temperature to make sure the child having fever or not fever? Can I have come answer for this? Is any of you using his hand, not using the thermometers to measure the temperatures? I'm talking about myself, yes. Dr. Ahmed, yes. Dr. Lama, yes. Sharif, yes. Yeah, here automatic, subhanallah, by ourselves once we want to measure, see the temperatures here. Yes, ما في حد no? Nobody no? Yeah, everyone yes. So any one of you have in kids, they are using their hand to measure the temperature? في واحد no, alhamdulillah. By the way, it's accurate, by the way. It's accurate to measure the temperature by the hand, but it's to rule the fever, to rule out the fever. So the forehead is the common site to take the temperatures. في study mentioning في 2008 mentioned the mother touching the multiple site of her baby, but no difference there. Using 10 systemic review حنشوفها الآن بسم الله. في study حصلت في ألفيس between 169 children of age of 2 months to 13 years. طبعا هو أخذ big populations in 2 months to 13 years old. التاتشنج here كان النك والأكزيلا والتمبريتشر more than 38, فكانت البريفالنس الفيفر كانت موجودة في 81% والسنسيتيفيتي كانت 75.9 والسبيسيفيسيتي كانت 90.6%. في another study كانت مسوية مع 1120 kids with various of complaints وكان عندهم fever touching the forehead, فحصل انه rectal temperature more than 38, prevalence of fever كان في 36.7 بس كانت very sensitive 97.3 بس specificity for that is 19.2%. الستدي طبعا طويلة many revising for it. But what you know, subjective measuring temperature by the hand, sometimes it's accurate. So maternally touch is perhaps more useful to exclude fever rather than to rule in fever. So you want to make sure the child having fever or no fever. So you want to exclude that. So I want by this way to make sure about it. لانه كثير من البارنتس they don't have temperature at the time فهم بيستخدموا يدينهم. انا my personal I'm using my hand to rule out fever with my kids. Does the high temperature or duration of the fever predict the risk of serious bacterial infection or mortality? Can I have answer for that? Just to know if there is fever or no fever when you are using your hand. No, yes, no, yes, yes, no. Yes, no, no. No, but we should respect high fevers. Okay. Yes. Yes. طيب. أروح للسلايد الآن. Does the high temperatures or duration of fever predict risk of serious bacterial infection or mortality? طيب. خلينا نشوف الآن. High and duration of fever. Most of the study was very limited here, but overall, temperature more than 39, sensitivity was 10 to 14% only to predict serious bacterial infection. يعني صار ما في فرق بين 38 و 39 وال 40. الفرق السنسيتيفيتي حقتنا هي 10 to 14%. كثير من الكيدز اللي هم عندهم serious infections, their temperatures may be between 38 and 38.5. Age and appearance better predictor طبعا. العمر والشكل الطفل افضل من انك تعتمد فقط على الهاي temperature والduration. More useful for young infant 2 to 6 months. Duration of fever here, weak associated between duration of fever and risk of serious bacterial infection. يمكن fever is more than 5 days or something, it's going with more chronic illness. Duration of fever and risk of serious bacterial infections, usually you need to, is not so that sensitive of durations and associated between fever and risk of serious bacterial infections, but you need to be rely more on the vital signs, on the age of the child, on the appearance of the child, on the back triangle appearance, breathing, and the color of the child. Many times parents here are best predictors, وأنا هنا بعطي big advice for myself. And the family sometimes when they feel something wrong is coming with the child, consider it. Plus, the parents are best predictor. I'm always also believe my gut. What's going on there? Sometimes your gut will give you something alarming. You need to believe it. So the parents and your gut, both of them, is very good for predictions. This is my joke. I'm not serious in this one. Huh? طيب is alternative common practice. احنا بنستخدم الانتيبيوتيك بنستخدم الايبوبروفين والباراسيتامول alternatively. How many of you you're using this methods? Ibuprofen, paracetamol every 4 hours. مين اللي بيستخدم موضوع البروفين بتاعت الفاميلي بروفين باراسيتامول بروفين كل 4 ساعات؟ Is it effective or not effective? كلنا effective. طيب هل تعلم انه الهيدريشن is more effective than the alternative of antibiotic of profen and paracetamol? To make sure about the hydrations and giving more fluid for the child, it's much more effective. Many studies they didn't recommend it. Sometimes they use it to calm the parents. Hey. Sometimes the parents, you use it to calm the parents, to decrease their anxiety. So we did tell them use it just to, but most of the time it doesn't work well, usually, especially if the fever pass more than 48 hours. عادة ما تكون يعني ما يكون لها أي effect يذكر. That's a common practice, not only here, it's around the world. Most of the caretaker report using this. Does it work? Maybe not. Sometimes it works in the first day because the temperature sometimes takes sometimes, but the biggest advice is make sure about the hydration of the patient. This is going to cool the child, not only the antibiotic by itself. Not big difference. It can lower the temperature for 4 to 6 hours per day طبعا. No evidence in overall improvement in other clinical outcomes. Parents' fever phobia can be worse. لأنه ما بيستخدموه. وعلى فكرة هي common area for wrong practice. لأنه ممكن الفاميلي they will make wrong dose or they will حيصيروا اللي عندهم wrong medications. They will be giving مثلا morphine every 4 hours by mistake. In general, most of the parents didn't notice big defect. وهذا فعلا بنلاحظه في الامرجنسي. Be careful can worsen the hydration of the patient. وإحنا دائما نقول إنه child once he's getting fever, especially when he going to the chill phase, هيروح تحت البطانية, he will be shiver more, he will be sweating more. We will give him paracetamol or ibuprofens. He will refuse to take in any oral hydrations, and he will lose more fluid from his body, and he will come to the emergency as a dehydrated. And unfortunately, in many cases, we notice it having urea is coming up. But don't depend on an antibiotic only. We need to depend also on the hydration status of the child. Many parents will confuse and need time to explain them in emergency. It's potentially area for errors here, wrong dose, wrong frequency. It will increase the risk of toxicity. And actually, there is one case last year of having liver damage. Actually, I think presented to one of the tertiary hospital in Riyadh. Risk of dehydration because we are not sometimes not keeping eye on the dehydration of the parents. Is it safe? Most of the time, is not safe. So you need to be very cautious when you prescribe it to the family. We need to be very cautious about that and instruct the family very, very, very well. Response to antibiotic. In any questions, does a failure to respond to antibiotic predict serious illness or no? Child عنده temperature 39, أعطيته بروفين أو paracetamol, there is no response. Is this one predict a bad things or no? Okay. That's my question here. Okay, good. Okay. طيب خلينا نجي السلايد الآن ونشوف. No different response for bacterial versus viral. وزي ما انتم عارفين انه maybe in the first 2 days it will be difficult to control the temperature لانها توها initiate الفيفر الان. فحاليا difficult to control it. It's maybe coming with a simple viral infection. Changing the temperatures 1 to 2 hours after the antibiotic doesn't help identify the serious bacterial infection. وعلى فكرة كمان ترى كل الانتيبيوتيك في الدنيا بتنزل التمبريتشرز 1 degree 1.5 degree فقط. يعني من 40 to 39 38.5. هذا حد الانتيبيوتيك. ما بتنزلها للنورمال temperatures. فموست of the antibiotic to bring the temperatures down to 1 to 1.5 degree only. The change in temperatures reassessment may be help and differentiate those with or without serious bacterial infection. Clinical exams, toxic ill appearance, and vital signs. The vital signs is very important. It can tell you a lot of things about the child. Is he sick or not sick? He's having benign fever or bad fever. Vital signs give you a lot of information. Don't ignore it. It's still the main to the predictive serious bacterial infection here. Does antibiotic prevent febrile convulsion? Yes or no? Child having history of febrile convulsions. When I told the family, start immediately antibiotic once you feel the child is getting fever. Is this one going to stop the febrile convulsion? Most of you, they said no, no, no. يمكن شفتوا من أمس تكلمنا عن موضوع الفيبر febrile convulsions في البيدياتريك نيورولوجي إنه many cases of febrile convulsions present to the emergency without fever, but they have history of fever. So here's the answers. All study here demonstrate that antibiotic will not reduce the recurrent risk of febrile cough seizures. Paracetamol, ibuprofen was ineffective to prevent recurrent of febrile convulsions. Again, I'm going to mention that the hydration is maybe much more helpful for reducing for the patient controlling fever more than paracetamol and ibuprofen. This will be adding to the hydration state of the child. Right, approach the child with fever in emergency. Case 1, we have 14-month-old girl present to the emergency with fever for 1 day. Previously she was healthy child. Today morning, wake up and had fever, no significant symptoms, good activities, good oral intake, immunizations up to date. On examinations here, she's crying, then playful. Temperature is 39.2, and the parents panic from this temperature. Pulse rate is 136, respiratory rate 28, blood pressure 85/45, and capillary refill is less than 2 seconds. No source of infection on the exams. So what's the differential diagnosis here? The common, yes, hydrations can reduce the temperatures. فاطفئوها بالماء كما قال الرسول صلى الله عليه وسلم. فايش الكومن diagnosis here? Sorry. It's a viral. This is what coming to our thoughts in emergency, but we need to think about, again, other differential diagnosis. Don't stuck to one diagnosis here. This patient, she may have serious bacterial infection. She may have meningitis, and she's coming to you in early course of the disease. She may have sepsis, meningococcemia, myocarditis is a common practice to be missed in emergency, etc. So we need to think wide about differential diagnosis, throw it out before we said this is viral. Viral usually, for expert people, the diagnosis after excluding everything serious with the child. You need to do that quickly because you're in an emergency. How to sort it out? History by the age of the child, duration of the symptoms, associated symptoms, and the immunization is up to date and relation to the season. في الexams طبعا هنعتمد كثير على الباك triangle اللي هي appearance, breathing of the child, type of breathing, and color of the child. Vital signs very important. Focal finding and clinical exam. What process thoughts as the clinicians here? Let's see it here. Assessment of the risk. We'll go to diagnosis, or will assessment of the risk go to the lab test and diagnosis that. In ill febrile child here, clinical symptoms in ill appearance of child will increase most probably serious diagnosis here. Lab test and start empirical treatment. Febrile ill child and diagnosis. Common practice that sometimes we are delaying the treatment of antibiotic for serious infection in a child like who's having sepsis, because we need to do like blood work and lumbar punctures, and we delay the antibiotic. This is common. This is sometimes conflict area, emergency, that we shouldn't delay the antibiotic to get the blood test or the LB from the child. Again, the age of assessment risk here, the age is less than 1 month, because if he's lacking of clinical signs, decreased immune response here, this is a common risk for the kids here. 1 to 3 months, now it's like an area of gray zones. Sometimes we have discussion if the child that looks well, healthy, feeding well, low-grade fevers, there is no highly concern about it, we can sort it out to be discharged. 3 months to 36 months, appearance and risk factors and occult infections. Also, the vital signs and meningeal signs after 1.5 years will be more clear. Kids more than 36 months, more clinical signs and more accurate clinical assessment and less risk of serious bacterial infection, and their immunity status is very good here. The common conflict area here are the kids between 1 month and 3 months, and most of you you know very well about the criteria, Rochester criteria, Boston criteria, Philadelphia criteria. Does anyone know about this criteria and which one you like to use it? Did you hear about Rochester, Boston, Philadelphia criteria? Any answer for that? Okay, and which one you like to use it? Or you have practice with it? اوكي بس you need to use one, you can't use it all together. طبعا هو باختصار شديد Rochester is applying below 2 months, Boston between 1 month and 2 months or 3 months, Philadelphia between 1 month and 2 months. Boston and Philadelphia, they are using CSF, but Rochester no CSF. And Rochester criteria less than 2 months, there will be no antibiotic, no chronic disease, no prolonged hospitalizations, history is clear, the child, he looks well, normal physical examinations, but CBC looks benign, between 5,000 and 15,000, less band, and there is no signs of UTI. Home, no antibiotic, but you need to make follow-up. Boston, لا بيقول لك كلها طبعا كلها well appearing child ونورمال physical exams لانه هذا دائما الكونفليكت حقتنا. Once a child is getting sick we know the pathway, but we are talking about well appearing child. Boston بيقول لك انه WBC less than 20,000, the urine analysis less than 10 WBC والCSF حيكون في اقل من 10, تعطيه ceftriaxone one dose, send them home, I need to follow up. فيلادلفيا لا ما فيها CSF but no antibiotic. ف WBC same, الباند, الurine no urine UTI, CSF is normal, home no antibiotic. So the only Boston who giving antibiotic, one dose antibiotic plus CSF. Rochester's no antibiotic, no CSF, just only blood work and urine analysis. Philadelphia blood, CSF, urine, no antibiotic. Assessment of risk here, you need to make sure about the immunodeficiency status of the patient, having HIV, cancer, sickle cell, whatever. This is a special group of people. If the child is on immunosuppressive therapy like steroid, chemotherapy, or immunomodulatory treatment like a patient with rheumatology, chronic illness like heart failure, and he's an anti-failure medication, metabolic disorders, cystic fibrosis, because this one will affect their immunity inside the lung, or overall the metabolic state of the child is abnormal and the immunity is unusual. Lying inside the body, any foreign body inside the body to be considered as a source of infection inside the body, either catheter, shunt, or whatever. All kids also post-OR within 2 weeks because he was ventilated and the lung is not functioning fully there. So you'll consider it as a risk factor here. Bronchiolitis. Bronchiolitis is when you present to the emergency with diagnosis of bronchiolitis, child is fever less than 90 days with RSV are at significant low risk of SPI. هذه سبحان الله العظيم many studies have been found. Patient febrile positive RSV عنده low risk of serious bacterial infection, but don't make it as a golden rule. No, but just we mentioned they having low risk, but not rule out SPI. But the problem is they may have some bacterial infections, which is the commonest is UTI, both male and boy, again. So the rate of SPI, especially UTI, remain there in febrile RSV infant. The commonest bacterial infection is UTI. What about that child who's less than 29 days and having bronchiolitis and having RSV? This should be go with full septic workup. This is out of the age that we're talking about. We are talking about from 1 month to 3 months. But the kids who are having less than 29 days, having bronchiolitis, RSV positive, fever, no, you need to do full septic workup. Assessment of risk here, appearance, irritability, lethargic, head and neck stridor, drooling, and neck pain, respiratory grunting, unexplained tachypnea, cardiac finding, cardiac something, unexplained tachycardia. Be careful about this point. When you have out of proportions of heart rate, more than 10 to 12 heartbeats, per minute extra for every temperatures, that we need to be think about something else. Any present of murmur, joints, arthritis, bone infections, skin rash, and petechia. All this be attention for it. Management of febrile infant less than 2 months, infant less than 1 month need complete evaluations and assessment and maybe for septic workups. Risk of infant more than 1 month need to rule out sepsis, whether to do full or partial septic workups, admission or versus outpatient, as we mentioned before, using Rochester's Boston, Philadelphia criteria. Empirical treatment or no, like what happened in the Boston, they're giving 1 shot of ceftriaxone. Make sure that you will never forget about herpes in the kids. Positive RSV infant more than 1 month still need at least urine investigation. But here, make sure the red flag, less than 1 month, still need complete evaluations because there is not enough data about it to rule out serious bacterial infection in kids below 1 month. Risk of UTI. Risk for boys uncircumcised if the temperature more than 39, fever more than 48 hours, and all sorts of fevers. We need to do cath for the child and getting urine to analyze it. Risk factor for girls is age less than 12 months, fever more than 39, here the temperature more than 24. So any kids, girl, present to the emergency, temperature more than 39, she's less than 1 year, and the fever within 1 day, you need to make about the type of screening of urine, especially if there is no source of fever. Attention, not all fever is an infection. Maybe it can be Kawasaki, oncology, rheumatology, drug reaction, we don't know, toxin other than the infection. Any child at any age need care for history and physical exams with fever. Fever is a symptoms, but not a disease and not diagnosis. We don't know that's fever. Is it benign or dangerous? We need to sort it out in ER, an emergency. We cannot quick assess the child within 1 or 2 minutes to say this is okay, this is viral infection, maybe having something else, especially with a repeated visit to the emergency. Lab test, are we going to do lab test for everyone with fever? So that's why we want to make sure about, don't make lab tests like fishing, just only throwing and see what's going on there happened. We'll do many blood workups just to see what happened there. We may have leukocytes, we may have something electrolyte abnormality, no. We need to be very specific in lab tests, especially in the crowded area like an emergency, to easily approach the patient and diagnose him and to hopefully discharge. Jazakum Allah khair, and this is my last slide. It's only study between UTI and bronchiolitis that's increasing risk of UTI. Tony, best only 2 minutes or 3 minutes. I will start the next lectures. You can put your questions. I need just only 2-3 minutes. I drink my water because I'm having sinus, so I need water frequently this time. والمرسلين سيدنا وحبيبنا محمد عليه أفضل الصلاة والتسليم إن شاء الله. نبدأ المحاضرة إن شاء الله الآن about the cardiac emergency. I hope my sound is clear for everyone now. Okay. Let's talk about the leading objects here. A list of common presentation of cardiac related to the emergency and describe the initial evaluations and treatment of the child who having potential cardiac in our emergency, and discuss the initials of investigation like NECG and X-rays. Structures here. Congenital, just keep in your mind, it's 8 to 1,000 left birth. Most of the cases present during the infant period and less than 2 months حتى بتجي emergency. 2 to 3 times incidence of preterm. 10% due to the genetic causes presented predicting of the cardiac will be diagnosed. Our major problem ومصيبتنا إنه في present to the emergency undiagnosed. Treat or untreat, we will face both sides, medical, surgical, or having temporarily surgical relief, cyanotic or acyanotic, sick or not sick. We have also some cases who present to the emergency with conductive problems like SVT, prolonged QT, digoxin overdose, or acquire Kawasaki endocarditis, pericarditis, myocarditis, cardiomyopathy. By the way, I faced maybe 4 cases who present with diagnosed infantile colic, but unfortunately he been diagnosed as SVT. The child actually he was been complaining from ischemic heart because prolonged SVT more than 2 days, not diagnosed in many hospitals and the clinic. And when we put the ECG, we found his heart rate 240 or 220. Looks SVT, and once we control SVT, the child came down. Fatal circulations here, we know that the child having different circulation than us because of having ductus arteriosus here. And once he's getting to the life and start to have first breath of oxygen to his lung, this area will start to have major modifications, and the BDA or ductus arteriosus will start to be shrinked and constrict and to start to be closed. So the child will not be dependent on any more on placenta to go, and he will not be more dependent on the right side to distribute the oxygenated blood. Now to be reverse, and he will start to depend on the left side of the heart to distribute to the oxygenation blood go to the systemic wall. That's why no more need for the BDA. Sorry. The common there is presentation here. The child can present with tachypnea, tachycardia, cyanosis, dysmorphisms. All unspecific symptoms bring to the emergency. Shock, seizures, sudden death, abdominal pain, chest pain, murmur, having many types of murmurs during our exams, harsh, diastolic, high pitch, thrill. He may present with the heart failure signs, can be gradual, can be sudden, can be start to have poor feeding, sweating from the face and the forehead, irritability is chronic cough, frequent chest infection, weak crying, irritability, poor weight gain. Poor weight gain, we should rule out always cardiac issues with a child. So present with a poor weight gain and poor growth in emergency, tachypnea, hepatomegaly, and gallop. The presentation that was essentially with the cardiac disease. Here it can be central cyanosis, like this, meaning the systemic artery desatting. More than 5 grams of oxygen is deoxygenated in the blood. Of course, the child who having sickle cell or severe iron deficiency anemia or thalassemia, it's difficult to see cyanosis with them because they don't have enough blood to make it deoxygenated. They need 5 grams out of the total blood having there is no oxygen to start to have this type of cyanosis. The site will be here: lips, mucus, membrane, nail, and it's central. And the child usually warm. Peripheral here, which is mainly more related, not for oxygen, more related to the temperature outside. That's meaning increased tissue oxygen extraction, often due to the perfusion problem, peripheral extremities, and oral. Patient is cool and calm. It's maybe combined, both central and peripheral. And here is one of the worst diagnoses in the cardiac disease, what we call it hypoplastic left heart syndrome, or there is critical coarctations. Both of it is life-threatening if not pick up very fast. And the prognosis for hypoplastic left heart syndrome is not so that good, but coarctation, they're having very good outcome. Central cyanosis here from right, because we have shunt here from right lung from right side to left side without oxygenation in the blood. There is problems of gait, so that's permit the blood coming without passing to the lung, either intracardiac, great vessels, or intra-abdominal. There is non-cardiac cause of more common, like pulmonary ventilation mismatch, like patients with asthma, cystic fibrosis sometimes, hemoglobinopathy also. This will be cause for cyanosis, but is not related to the cardiac. Ductal dependent lesion. You should be suspected in any infant in the first week of life who's presented with sudden onset of circulatory collapse, hypoperfusions, hypotension, severe acidosis, cyanosis. Infant here may be present in the second week of life. Actually, it's maybe up to 2 months. You need to keep an eye on that. Rarely present after the 4 weeks of age. Ductal dependent lesion here, which is our nightmare, not to be missed in emergency. Ductal dependent here, pulmonary blood flow, pulmonary atresia with intact septum, tricuspid atresia, critical pulmonary stenosis. Here is ductal dependent lesions that prevent blood to go to the systemic blood flow, like coarctation of aorta. So we need the PDA here is open, aortic arch interruption, or hypoplastic left heart syndromes. And all diagnosis here, we need to keep the ductal open. It's life issues. If it's closed, it will be life-threatening. Remember here, if you suspect ductal dependent, start prostaglandin even before the echo, especially in the periphery hospital. Prostaglandin here infusion is very simple. We can remember the dose is 0.05 to 0.1 mic per kg per minute. And advanced, we can go up to 0.2 mic per kg per minute. Usually this is inside the NICU or PICU or cardiac ICU. Adverse events that we need to effect of that one. That's why most of the time we need to intubate the patient with prostaglandin because the child will have a frequent apnea due to the prostaglandin. Better to intubate him with the start of the prostaglandin. Hyperthermia, common, hypotension, rash, tremor, and focal seizures and bradycardia. Questions need to be known here about it. Is the patient cyanosis or not? Remember the 5 T's, or look to your fingers here. 1 is meaning truncus arteriosus. 2, it means twitching, transposition of the great vessels. 3, that's meaning tricuspid atresia. 4, meaning tetralogy of fallot. This is common sites of cyanosis present to the emergency. Or 5 fingers here, which is total, it switch everything. That means total anomaly, pulmonary venous drain there, which is the problem you see with the coronary arteries, and they may having received the cardiac or receiving deoxygenated blood, and will be prone to the ischemic or MI, la qadar Allah. Others, tens of there is another diagnosis here: single ventricles, hypoplastic left heart syndrome, pulmonary atresia, double aortic. But this is the commonest diagnosis here. Right. How about the pulmonary blood flow here? Patient with cyanosis. It will be increasing the blood flow here if there is transposition, diagnosis of transposition of great artery, total anomaly pulmonary venous drain, truncus arteriosus, hypoplastic left heart. So the lung will receive more blood than usual. Here, the cyanosis patient will have cyanosis, but he will having oligolungs or lungs not receiving enough blood. This is in tetralogy of fallot because the valve of pulmonary valve will be restricted out to flow the blood to the lung, or the tricuspid atresia, so the blood will not go from right atrium to the right ventricle then to the lung freely. So the lung will be receiving less blood here. How about here's the patient about pulmonary blood flow, but there is no cyanosis. It's happened here. And VSD, the blood flow will be increasing in the lung. ASD, patent ductus arteriosus, or atrioventricular septal defect. It will decrease here the blood going to the lung with cardiac patient and pulmonary atresia, aortic stenosis, aortic coarctation. Time of presentation here, we need to be careful about the patient when he presents to the emergency. How is his age? Between 0 to 2 weeks, TGA, transposition of great artery, total anomaly pulmonary venous returns, hypoplastic left heart syndromes. All three diagnoses can be present in the first 2 weeks of life. Up to 1.5 months is truncus arteriosus, tricuspid atresia. Up to 6 months, AV canal defect, VSD, ASD, arrhythmia, TETOF or tetralogy of Fallot. It can present at any age. Actually, this case has been discovered. He's 65 years old, by the way. Meningeal syndromes or pulmonary hypertension can present late age after 5 years of age. Aortic coarctation can present at any age, but severe coarctation may be present in the first 2 weeks of life. Aortic stenosis, the same thing. Coarctation and stenosis also the same. Aortic stenosis can be diagnosed at adolescence age when the child starts to be more active in athletics. So we will present with the syncopal attack and exercise intolerance. Timing of presentation. From 0 to 2 weeks, ductal dependent lesions, we need to be kept an eye, hypoplastic left heart, aortic coarctation, aortic stenosis, cyanosis. We will look to the 5 T's that we mentioned before: truncus arteriosus, transposition of a great artery, tetralogy of Fallot, etc. Will still the timing of presentation here from 2 to 6 weeks. Heart failure, basically present with the heart failure, VSD, BDA, AV canal. Cyanosis here will be remaining with, we'll remove the tetralogy, transposition of great artery. It will remaining with truncus, tetralogy of Fallot, and tricuspid atresia. 6 weeks to 6 months, patient still can present with the heart failure and VSD, ASD, AV canal, cyanosis. It will be the only one that will be remaining of it of tetralogy of Fallot. Childhood, adolescents, mainly the ASD, they will present with complication of ASD or arrhythmia, BDA, aortic or pulmonary stenosis, hypertension because of aortic coarctation, syncopal aortic stenosis, or meninges. Meninges can happen after 5 years, and aortic stenosis can be diagnosed at any age. Evaluations here in emergency here by the age, birth history, heart failure symptoms, and cyanosis, and family history. Physical exams, always, as we mentioned, PAT triangle is the most important steps. Pediatric assessment triangle, look to the appearance, the breathing, type of breathing, and the color of the child. Careful look to the vital signs, to the color of the child. Is he cyanotic or not cyanotic, or he looks gray? For extremities, the blood pressures, so we need to be careful about diagnosis of coarctation, aortic stenosis. Pre- and post-ductal oxygenation saturation, the right arm and either leg. Auscultation for murmur and extra sounds and hepatomegaly. Let's see the cardiac patient in between of tons of bronchiolitis. We may have bronchiolitis case, and one of them is present with picture of bronchiolitis, but actually his heart failure. Hyperoxic test here, 100% of the oxygen for 10 minutes. That's how can we make hyperoxic test. If the child improves, that's meaning he's having respiratory issues. If no improvement, that's meaning it's central cyanosis coming from the cardiac. There is no improvement. I need to be careful about giving oxygen because it may be BDA. X-ray, we need to look to the size, shape. We look to the blood, pulmonary blood flow there. Pulmonary edema. ECG, we look to the anticonductive issues, is it SVT or what else? Rhythms, hypertrophy, and ischemia. We'll go case by case and quickly. This is 9 days old, actually, female brought to the emergency by the mother. history of rapid breathing, decreased oral intake. She's this active today, no fever, cough or vomit or diarrhea. Physical exam, temperature is 36.7, respiratory rate is 80, is high, heart rate is 180, weight is 3.6, capillary refill is more than 3 seconds. Increased work breathing, grunting, tachycardia. She looks gray, the child. Galoprythm, liver enlarged, generalized hypotonia, pulse is weak in the distal and the lower extremities. So what's the differential diagnosis here? We mentioned it. Coarctation, COA, main coarctation, ductal dependent, okay? 9-year-old, okay? To think always about once the child having decreased oral intake and looks lethargic and looks gray, about septic shock, septic shock, septic shock. Looks to the pulmonary side, dehydrations, intracranial hemorrhage maltreatments, metabolic abnormality, and cardiac. Are you agree about this? We're still in case 1, time of presentation from 0 to 2 weeks. So we need to think about cardiac issues, cyanotic cardiac, truncus arteriosus, transposition of the great artery, tricuspid atresia, tetralogy of Fallot, total anomaly, pulmonary venous return. Looks to the ductal dependent lesions here, hypoplastic left heart, aortic coarctations, or aortic stenosis. So this patient, why we use this ductal dependent? He was gray also, and there is different in the blood pressure also. So this is a child, we're still in case 1, by the way. He's a great child, poor pulse, poor perfusions. It's ductal dependent to the systemic because he's gray. Great child and capillary refill more than 3 seconds. We think more about coarctation of aorta and aortic arch interruptions and hypoplastic left heart syndrome. Case 1 came the blood gas 7.1, carbon dioxide 30, oxygen 72, hemoglobin 16, leukocyte 12,000, glucose 150, bicarb only 12 because of the perfusions in the body. There is mild cardiomegaly and sinus threatened the ACD. The case ended up by diagnosis of interrupted aortic arch with large VSD. Alhamdulillah, there is a large VSD, so he can open it and mix with the blood. Ductal dependent lesion, systemic flow. Now more left to right shunt here because we have close aortic coarctation there. So the blood flow from the left to systemic is interrupted here. So here the problems here. Once the blood coming here, we need to keep this one open quickly. IV fluid, prostaglandin to keep open the BDA, but the beta ductus arteriosus, open it and not make it out close. Decrease the oxygens to the child, positive pressure filtration, and they need urgent repair. He needs to be sent to be urgent to the OR. So in summary of case 1, circulatory collapse less than 1 month. It is ductal dependent till proved otherwise. Airway breathing assist ventilation as required. Don't want to be saturation 100%, otherwise we'll make the BDA close fast. Circulation fluid, prostaglandins 0.05 to 0.1 mic, and we can go to up to 0.2 mic per kg per minute. Make sure you're ready to intubate the patient to prevent any side effect of the apnea. Empiric sepsis treatment, of course, we need to start because we don't have definite treatment for this case. Case 2, cyanotic in 2 weeks old. He's tachypnic. He's no murmurs. Let's think about 5 T's: truncus arteriosus, TGA, tricuspid atresia, tetralogy of Fallot, total anomaly pulmonary venous drains. This is the picture of the heart. What it looks like. What is the shape of this heart looks? What we call this? Egg on sling, okay? Egg on string. So what is this case diagnosed for what? Okay. It's TGA, transposition of the artery. So cyanotic in 2 weeks old is having TGA. That's meaning left ventricular to the pulmonary trunk, right ventricle to systemic flow. Here, 2 separate circulations here. The presence of PDA is actually mandatory to keep the child alive and allow mixing of oxygen and deoxygenation in the blood for that. So immediately we need to start prostaglandins to keep this PDA open. And once being diagnosed and availability of cardiac surgery, we can send them direct for simple ligate for simply switching the both flow. The major complication of TGA in the operation room is the problem with the coronary artery when they miss it or cut it or the wrong insert it. The child will having immediately after the OR ischemic heart disease and very bad prognosis for that. So most of the cardiac surgery, they are aware about this issues here. Cyanotic in 2 weeks old, tachypneic, hepatomegaly. Let's think about 5 T's. And this is the picture of the X-ray. What is this? What is the picture for what? Snowman for what? Figure 8 how this is in the elbow trauma. Okay, so this is snowman, and this is, you are right, total anomaly pulmonary venous retains. Cyanotic in 5 weeks old, tachypneic, murmurs, hepatomegaly, having heart failures. So let's think about heart failure, VST, BDA, AB canals, and cyanotic, and cyanotic about 3 T's, because we already removed that transposition of great artery. We remain by the truncus, tetralogy of Fallot, and tricuspid atresia. Total anomaly pulmonary venous is not present at this age, usually present earlier. And this is the X-ray. This is X-ray for what? This is what we call it, wall-to-wall heart, meaning big heart. This happened with tricuspid atresia. Once the valve on the right side being closed, make the heart big. 4-month-old cyanosis with agitation, murmurs, ECG, right ventricular hypertrophy, right atrial enlarged. From 6 weeks to 6 months, heart failure, VST, AST, AV canal, and cyanosis will remain by tetralogy of Fallot because it's 4-month-old. What is this picture of what? X-ray. Boot shape, yes. Yes. This is a boot shape. So this meaning of tetralogy of Fallot. This patient, when you present with emergency and already you have the diagnosis for tetralogy of Fallot, just don't treat the child with the IV fluids and make him panic. No, let him come down and with the mother hands, knee, chest, use it, give oxygen, and also give an IV fluid. Try to make less pain as much as you can. Case number 6, 8 weeks old male who is presented with lethargic and decreased activity, poor oral intake. Vital signs is 38.4, is febrile, pulse rate 240, and respiratory rate 60, blood pressure 70/50, saturation 92. Is a respiratory distress, mottled skins, liver is having hepatomegaly 2 centimeters below costal margin. Blood gas here, pH 7.1, and bicarb only 9. Leukocytosis 23,000, and hemoglobin 10. X-ray slightly enlarged heart size. What is this? So here we should keep in our mind septic, pneumonia, cardiac. Treatment here for this patient, he ended up by intubations. He was very sick and he looks septic. Lines and fluid by carb given, ampicillin, cefotaxime, and then reassess. No improvement. Mottling capillary refill around 5 seconds. Tachycardic. So remaining by using another differential diagnosis, non-cardiac cause for tachycardia, what we call it 4 H's, 4 T's. 4 H's like hypoxia, hypovolemia, hyperthermia, hyper and hypokalemia, metabolic. 4 T's is tamponades, tension pneumothorax, toxin, and thromboembolisms, plus minus present of pain and anxiety and fear, etc. This will increase the heart rate. Sinus, but usually sinus. What is this? ECG here. Was kind of interrupted. So this is actually the picture of ECG is about the SVT. We have 2 types of the SVT, either stable or unstable. That's why the course of pediatric advanced life support is so mandatory for all pediatricians. When we're having unstable SVT, that's meaning we need to go to the shock the patient will synchronize the cardioversions. We'll start by 0.5 joules per kg, increasing to 2 joules per kg as needed. You need to give some sedation because it's painful, and most of the time the child will be awake. If it's stable SVT, stable vagal maneuvers is no more used now. You can use ice bag on the front of the head, but also is not anymore recommended. And يمكن اكثركم استخدموا موضوع الايس باج وما لقي بنفيت كثير منها. الادونيسين our solutions here medications is we start by 0.1 milligrams per kg, the maximum 6. Then you can double the dose if no benefit, 0.2 milligrams per kg if it's recommended. If you have a recurrent SVT, that's meaning you give adenosine and stop, and you give second dose, stop, and come back again SVT. Start to use anti-arrhythmic medications. You have 3 choices here: procainamide, 15 milligrams per kg, bolus over 20 to 30 minutes. You don't give it push because will make major hypotensive, this procainamide. Amiodarone also 5 milligrams per kg, given over 20 to 60 minutes. Verapamil not routinely being used. Case 7 here, it's a 7-year-old boy was at home, become unresponsive, staring, incontinent of urine, no significant past medical history or trauma or cardiac, no family history of sudden death or cardiac disease. CPR done by the family because the family, they are educated for CPR. They start CPR for the child until the resident arrive to their home. Differential diagnosis here, the child can be having seizures, trauma, and witness ingested something, can be cardiac dysrhythmia, myocarditis, and heart disease. So let's look at some differential diagnosis from the cardiac issues here about the syncopal aortic stenosis because chest pain, dyspnea on exertions, murmur harsh with a click. Hypertrophic cardiomyopathy, which is one of the unfortunately major cause of sudden death between the athletics. The child may be having some murmurs, death in case with Valsalva, dyspnea, chest pain, palpitation, arrhythmia, palpitation, dizziness, and associated with the sudden sounds. Heart disease like tetralogy followed transposition of great arteries and any cardiac surgery before. When we talk about transposition of great artery and tetralogy followed, because the correction of the surgery, they may be interrupted the coronary arteries there, and they may have illness later on. Also the same with the patient having Kawasaki disease or disorder, late diagnosis, they may present with issues with their coronary issues. History here, past medical history, cardiac disease in the family or the patient by itself, dizziness, chest pain, short of breath, palpitation, and they're having rapid recovery. Physical exams here, orthostatics not specific to vasovagal, auscultation, rubs for gallop and rhythms. ECG looks for the prolonged QT intervals, Wolf Parkinson, WPW, and looks for the sign of left ventricular hypertrophy, and then to the definite diagnosis by the echo. Hypertrophic cardiomyopathy, it's a common cause of sudden death between the athletics, even youth or in the 30 years or 35 years old. We can hear that some athletics or play footballs, when they play football and they're having sudden death in front of all the attendants there. Left side hypertrophy, outflow obstruction, dysrhythmia, that's maybe getting worse with the exercise. The percentage is 1 to 500, half million. Between 1 to half million, you have one athletics having this problem, hypertrophic cardiomyopathy. That's why nowadays they start to do pre-assessment with echo for any athletics going to the football. They will do pre-assessment echo for them, mainly in the male, and it's unfortunately it's autosomal dominant. What is this? What's the side type of ECG? This is unfortunately child who have undiagnosed of prolonged QT interval or WBW, and then develop sudden arrhythmia. This is how to calculate the this is how to calculate the prolonged QT intervals here. Once you need to calculate the QT divided by the root for the RR. And once we calculate the RR is supposed to be from the square before, not from here. No, you need to calculate the square before the waves. This is how we calculate the RR here. Here is the shape of prolonged QT intervals, what happened because the QT here, how is long, and prone for arrhythmia for any stress or any medication or anything that's happened here. Initial evaluations, critical history, chest pain, syncopal family history, vital signs, exam, ECG, we came to that one, saturation, and X-ray. Some fact about pediatric chest pain. It's happened in all age groups, 3 to 5% of them, they are cardiac disease. So be careful, not over-diagnosis muscular pain or pneumonia or something, or trauma, because maybe out of 100 patients present to the emergency with the chest pain, you may have 3 to 5 of them having cardiac illness. Common cause less than 2 years, cough, asthma, pneumonia, heart. More than 2 years, having idiopathic costochondritis, asthma, chest wall strain, heart disease. The common non-cardiac for causing for chest pain, either trauma, costochondritis, pericardial catch, lung, like pneumonia, effusion, and GI reflux. Chest pain, cardiac cause, structural, like aortic stenosis, pulmonary stenosis, hypertrophic of cardiomyopathy, mitral valve prolapse, aortic dissection as a measures. Coronary arteries here, the problems you think about Kawasaki, anomaly of coronaries, coronary artery disease, or patient who present with post-operation pathology of fallot or transposition of great artery, inflammatory like pericarditis, myocarditis, arrhythmia, SVT, BVC, VTEC, and chest pain. In Western, they seen a lot of cases post-drug ingestion like cocaine, amphetamine, and they present with cardiac issues and arrhythmia there. Chest pain, we should keep an eye about the red flag here about chest pain. When the chest pain happens with the exercise and it's continuous and recurrent, syncopal with exercise, recent chest wall trauma, an examination for any murmurs, we need to detect outflow obstructions, any abnormal in ECG, evidence of trauma, teenagers with chest pain and hypermobility joint, a history of URTI and complaints from fast heartbeats, facial butterfly rash like SLE, you need to make sure about there's nothing, and chest pain because this will lead to the pericarditis. Last case, this 8-year-old boy present with a fever, arthralgia. Mother mentioned that he having sore throat for 3 weeks. I'm not sure there's time for that, but let's go quickly for that. It's acute rheumatic fever. It's school-age children associated with a certain strain of group A, streptococcal organism simulation antibodies. The main thing is the carditis, and it happened after 2 to 6 weeks post-streptococcal pharyngitis. We need to remind this picture for John criteria to diagnose acute rheumatic fever. Major criteria that we need 1 plus 2. It's carditis, new change murmur, cardiomegaly, pericarditis, migratory polyarthritis, chorea, erythema marginatum, subcutaneous nodules, and the minors including fever, arthralgia, history of previous acute rheumatic fever, elevated ESR, CRP, prolonged PR in ECG, rising titer of anti-streptococcal antibody. By those I mean you need to make this supposed to be signs of presence of streptococcal or antibodies of against streptococcal. Thank you so much. I'm sorry I take more than 40 minutes for every lectures. I'm trying to make it fast in the last few slides. And then I'm happy for receiving any question now. Thank you very much all. جزاكم الله خير يعني.
Pediatric pain management and how to manage pain in pediatric patient arriving to ER, and how to assess them, what is the best, pain medication can be given, and how we can handle pain. So let's start, go back to the world history a little bit before we discuss, the new recommendation for pain management. As a myth, I'm not sure that we still, many, I think, healthcare providers believe that, young infants don't feel pain. And this is a kind of myth. Children also easily became addicted to narcotics. Still, many healthcare providers think that the children, they might get addicted when we prescribe them, pain medication or narcotics. Children tolerate pain better than adults. This is also a universal belief that, children can tolerate pain, and children are unable to tell where the pain is, or where, the pain is hurting. So all of this, bullet points that mentioned are considered myth. So what is the truth? The truth about pain in pediatric, that the central nervous system actually start developing at 26-week gestational age, and start to experience and receive nociception, for the fetus. And also less than 1% of children treated with opioids develop addiction. So this is a very low risk of addiction when it comes to patients who are treating with narcotic to have such, addiction. Children tolerance to pain increases with age as well. As they grow up, they need more doses, okay? And what was, helpful when they are 2 years might not be helpful when they are, 6 years. Children can express and identify pain with the use of proper pain assessment scale. And this is very important. What pain assessment we are using for them to quantify the pain, to assess the pain, to recognize the pain. So all of this, depends on what scale. So if we are using the right scale, we will be able, to quantify that pain and see what, pain medication can be given to those patients based on their presentation. So why is pediatric management inadequate? So in many cases, many occasions, we see pediatric patients are not treated very well when it comes to pain management. And what is the reason behind that? There are many reasons actually that can be contributed to inadequate pain management in pediatric population when they are, accessing emergency departments. One of the first ones are fixed IM dose of narcotics prescribed, and exaggerated concern about the side effect. Many healthcare providers, many emergency physicians, fellows, residents, they having, they exaggerated, concerns about, the side effect of medication. They get afraid, they get scared, of giving pain medication because, they don't want, the side effect to happen to the baby or to the child. And this is actually a wrong perception, a wrong, in the physician. They should, and with the healthcare provider, change their mentality that those medications are safe when they given right dose and right, medication. Delegation of pain treatment. Sometimes, this is get delegated to a senior resident, to fellow, who are sometimes not aware exactly about, what is the dose, what is the regimen that can be given to this pediatric patient. Lack of positive reinforcement. And the most important, I think I see a struggle is the belief that children don't feel pain. And inadequate knowledge about pain management when it comes to pediatric, and problem with pain measurement. And this is also a huge obstacle, that we see. In order to treat patients very well, we need to quantify the pain, we need to assess the pain level. And if we are not using the right tool, if we are not using the right pain assessment scale, we won't be able to have, a happy child, leaving the ER. What are the facts about the pain? The infants, regardless of their age, they feel a pain. The youngest premature infant has anatomical and physiological components who perceive pain or nociception and demonstrate severe stress responsive to painful stimuli. So this is a fact, this is not a myth, okay? And this should, alert us, change our, mind that, those kids, they feel severe pain. And as we spoke earlier, the central nervous system starts to receive nociception and messages about these pains from the age of 26 gestational age. Newborn, complete myelination of the nerve pathway not required for pain transmission. The C fibers are unmyelinated and A delta fibers are thinly myelinated. Incomplete myelination results in slower conduction velocity, but which is very important, offset by shorter distance of their nerves. The newborn, they have a complete myelination of pain pathway to brainstem and thalamus by the 30 weeks, as it should be started at 26 weeks of gestational age. However, this is developed, by the 30 weeks, and to the cortex by 37 weeks. Nociceptive nerve endings in cutaneous and mucous surfaces by 20 weeks of gestation. So we have this, the central nervous system and nociceptions of these pain messages started at, earlier at the 26. By the 30 weeks, they will have a developed pathway for receiving, messages about the pain. Stress responses to post-operative pain in neonate. If we're talking about the neonate, exactly, there are biochemical changes, stress hormones, corticosterone, adrenaline, noradrenaline, glucagon, aldosterone, metabolites, glucose, lactate, pyruvate. All of this chemical changes with the stress hormones, is a response to the stress in a post-operative pain. The facts about pain in infant and children. Unrelieved pain in infants can permanently change to their nervous system and maybe prime them to having chronic pain. And this is very important. The more messages, from the pain center, okay, to the nerves, it ends finally that, there will be no response from the or from the biochemical changes that we spoke about, these hormonal changes that comes from the stress. If you go back to the slides, we said there's a biochemical changes, stress hormone, adrenaline, noradrenaline. This pathway, the biochemical changes, after a while, from having continuous messages, this will having patient to be having chronic pain. They will not show any sign of physiological changes or behavior that will tell you that this patient have a pain. Children do not tolerate pain better than adults. And this is also a golden rule. And children's tolerance to pain actually increases with the age. So as they grow up, okay, their tolerance to the doses will require, more, doses to overcome the same pain that they used because they are growing up. So we shouldn't be treating them, with the same dose that was being given when they were 2 years ago. Can children tell where is the pain? Yes, they can. Children beyond infancy can accurately point to the body area or mark the painful site in a drawing. Children as young as 3 years can use pain scale. And we, as all of you have seen, and I've seen, babies when they have, pain, they start, pointing their fingers to that. If they have otitis media, they will show where's the pain, even if they are, 8 months or 9 months, so they still, they can pull the ear because the ear is hurting them. They can point to the tummy because there's abdominal pain. And if there's any other size, they will try to, point to that with their fingers. Now, do children tell the truth about the pain? One thing that we have to understand as a healthcare provider, and that children usually they don't lie. So they always say the truth. However, sometimes may they not admit having a pain to avoid injection. So being scared or afraid from the hospital and know that you're getting injection for them is a painful experience more than the pain process itself. So sometimes, to avoid this experience, they may, go and say they don't have pain, or they don't, and that's why, because they believe they know how they are feeling. Children do not become accustomed to pain or painful procedure. Children often demonstrate increased behavioral sign or discomfort with repeated painful procedures. So regardless, even if you have patients who come, or pediatric patient who comes to have accessing the AD, oncology patients, okay, it's a painful procedure, regardless if he is like, a customer that he visited, the clinic or the inpatient, every week, or to get a chemotherapy. This is a painful procedure. Being accustomed to this procedure will not, make them, always without pain. It is painful. Children do not all, sorry. Okay, so this is a study, just to show you the consequences of inadequate analgesia during painful procedure in children. So there are 21 children in the study, and they tested, bone marrow aspiration with lumbar puncture, randomized study versus placebo, okay, with a transmucosal fentanyl. So the two groups, okay, one group received placebo and the other group and received, transmucosal fentanyl. Now the placebo group rated their pain higher than, the transmucosal fentanyl group. Then the placebo group then received transfentanyl. Children less than 8 years, number 5, still rated pain higher than the transmucosal fentanyl group. And this is show you the importance of having, pain is not inadequate, during analgesia, during the procedures. Behavioral manifestation of pain may not reflect the pain intensity. Children developmental level, coping abilities, temperament, and such as activity level and intensity of reaction to pain influence the pain behavior. So we always not, depend on their behavioral manifestation to quantify or to see the intensity of their pain. And always remember that the parents, they want to be involved in their child treatment or pain control. Parents, they need information, assessing pain, using intervention to relieve pain, how frequent they can give the pain medication, when should they give the pain medication, should be, they should understand when to give it before, the crisis starts, before the pain process, kick off. They need to give this pain medication because it would take more time, if they start, their pain process and they became in severe pain, to bring their pain to normal or no pain. So it is advisable, to explain to the parents that, once the pain, signs started, or to give the pain medication ahead of the pain, so it can be actually prevent, exacerbation of their pain process. And this is very important to get the family involved in this. Guys, do you hear me very well? Are you with me? Can you answer, please? Okay, excellent. The other thing also, narcotics are no more dangerous for children than adults. So addiction from narcotics, opioids used to treat pain is extremely very rare. As we said, it is less than 1% in adults. No reports substantiate the fear in children. Reports of respiratory depression in children are very rare, so they are safely can be given to pediatrics. We can control them, we can manage them when they are in the ER. Now, definitions always confused with the addictions. Involuntary and physiological responses, like drug tolerance, where the healthcare provider needs a large dose of opioids to maintain the original effect. And when the patient also complains of physical dependence, that he will show some withdrawal symptoms when the chronic use of opioids is discontinued or opioid antagonist is given to the patients. So these two terminology with physical dependence or the drug tolerance. And I will emphasize more in the drug tolerance because we need to understand that patients, especially in pediatric, their developmental growth changes day by day, and we need to put in our mind that those doses they need to be increased to give the same effect and to control the pain, especially when the patients start to grow up. Even for adults, the drug tolerance also sometimes need to be adjusted to give the same effect. Now, narcotic addiction behavior and voluntary pattern, this is characterized by compulsive drug-seeking behavior, leading overwhelming involvement with procurement and the use of opioids not for a medical reasons. And this has become like, a drug seekers patients. Now, all of you know the universal, definition of the pain is whatever the experiencing person says it is, existing whenever he says it does. And this is very important that the pain is subjective, we're taking the patient's own words and the child own words to transcribe it, that this is what he's saying, and believe the patient. That's the most important. We should have to understand and believe that what he's saying is the truth, and what he's saying is existing, and based on that we can treat the patient adequately. Now, what is the fact? That children's pain continues to be poorly controlled. Pain during procedures, surgeries, post-operative pain, disease-related pain, are inadequately controlled. And this is, being documented and noted that, the pain is not well controlled when it comes doing procedures, especially for pediatric. We're talking about, lumbar puncture, we're talking about, nasogastric tube, we're talking about invasive procedure. Those patients, they need to have a full control of pain while they are doing the procedure. Not only that, for the sake also of the pain, children and pediatric, in order to have the procedure done, they need to be calm, they need to be relaxed, okay? They are not like the adult, they understand, okay? And you will not be able to control them physically without having, a physical control also for the medication and the pain. End of life, we're seeing also, because now our patient complexity became, diverse, and we have a lot of patients as, the health education system and became more advanced, and we're seeing a lot of patients who are coming to the ER who are at the end stage of their life, cancer patients who are, not for any chemotherapy or radiation or surgical intervention, and those patients, they suffer severe pain. So are they treated very well in emergency? Are we able to, handle their pain and, attend their pain, treat them very well? A survey of 103 patients whose child died, of cancer between 1990 and 1997. Interviews conducted average 3 years after the death, focused on quality of life during the last month of life. And what was the result for this? 89% of children suffer one of 4 problems. I will talk about these problems. 50% suffered from 3 or more, like fatigue, poor appetite, pain, treated in 76, successful, in 27, dyspnea, and treated 65 in 16%. So we're still having, also in the end of life care for those patients who are not, entitled for any other, surgical intervention or chemotherapy or radiation to control their pain and the symptoms that comes with the end life, from decreased oral intake, from fatigue, from weakness. So for the pediatric pain management, there are 4 aspects must be, addressed: the physical, the psychological, social, and spiritual. The last 3, when we talk about psychological, social, and spiritual, can be met only after pain and related symptoms are controlled. So once we control the pain, the rest of 3, psychological, social, and spiritual, can be met. without, you know, controlling the pain, these three cannot be, you know, achieved. Questioning the patient, the pediatric patient, about the pain and rating the scale. To evaluate the behavioral and physiological signs, secure the family involvement, take a cause of pain into account, take action, and assess effectiveness. We need to get the scale, we need to assess the patient properly in order to have the right treatment for them. Question the child verbal indications of pain. Much less common than the adult, may not be understand the term. So sometimes the word pain maybe is not, you know, common for the pediatric population, for the children. They may not understand what the pain means for them. Maybe there are some other sentences or phrases you may use to communicate with the child, at least, you know, to get a hint about if he's feeling pain or not, such as like, I don't feel good, may deny pain for fear of injection, cries, screams, groans, moans. As we said, you know, children, usually they may deny the pain, or they will not tell you that they have a pain because they are scared from something, you know, that may cause more painful experience for them, which is like injections or needles. So that in this way, they may hide that they have a pain. Now, what we can use for them? You need to, you know, go to their level. You need to think that you are, think like they think. You think like, speak as they speak. You need to speak their language, so they don't say pain, okay? And when they having a pain, they may, you know, describe the pain such as ooh, boo, ouch, hurt, oh. So all of these, you know, terminology, you may use it, you know, to come around and to get to know if the child has a pain or not. So we need to speak their language, so in order to understand if they have a pain. Having the child located where is the pain, marking the body parts in a human figure, drawing. You might ask him to draw my one finger, you know, to point. You might ask him to point on a doll, on an animal. Where is your, or you may ask him, where is your mommy or daddy will put a bandage. So, you know, at the end, you need, as we said, you need to speak their language. You need to go down to their level of thinking, of terminology, and you need to be, able to speak, you know, in their language, so they can answer your question. Now, this is exactly if you are speaking English to somebody who's speaking Chinese, so you will not have no answer from them. So you need to speak their language, so in order to have a better communication, to build a trust, so they can tell you exactly where is the pain. Now, the most important thing is pain rating scale. Select the right tool, suitable for the child age, ability, preferences. Teach the child to use a scale before pain is expected. Okay, such as preoperatively, use same scale with the child each time pain is assessed. Ask the child acceptable or functional pain level. We'll share with you some of this, you know, pain scale. The numeric pain scale. Yeah. Some of the comments, they said, you know, it is easy to say all of this, you know, but it is difficult actually to apply it. Yes, I do agree to some extent, but I think also we need to try. You know, the more you try, the more you will have, you know, the ability to get those children engaged and try to understand how they feel the pain. Now, most of us, you know, they might be, you know, in a hurry, rush, busy ER, you know, and we don't pay too much attention to the to the pain, okay? And we're looking, okay, to get a diagnosis and treatments in patient home or admit patients, you know, decrease congestion of the ER, okay? But this is the whole experience for, you know, pediatric or a family. It is very painful. We need to put that in our mind as healthcare provider. It will not, you know, disappear from their mind. And those kids, they need to come to the hospital sometimes for family medicine appointment, you know, for follow-up, you know. If they have a bad experience from the beginning, you know, believe me, they will have, you know, family will struggle with them to bring them back, you know, for any appointment. So let's make, you know, their, you know, visit to the ER or to the hospital pleasant, so they can, you know, we can make sure that, you know, their health will always be monitored and assessed. So this is a very simple, as we said, we can use it pre-operatively, we can use it before the procedure, before the pain is expected, and it has the faces of the child, you know, easily can point where is the pain. Now the FLAC pain scales, and this is sometimes difficult to assess pain in children who are non-verbal or non-communicative, or who refuse to communicate with you as a healthcare provider. The FLAC pain scale is a system that can be help parents and professionals to assess pain level in children who are not expressive communication. As all of you know, it contains, you know, 5 elements. You have the face, the leg activity, cry, and consolability. And it scores from up to 10. So 7 to 10, the patient is having severe discomfort, severe pain, and the patient from 0, he's relaxed and comfortable. We need to get this, you know, posted in emergencies. So, you know, healthcare provider, nurses, physicians, they can easily look at this and see, you know, how they can use this scale for pediatric patients, children who are not communicative or who's not expressing themselves. Behavioral pain rating scale for infants and non-verbal children use appropriate, you know, observational scales. We have the cries, we have the FLAC, we have the neonatal pain agitation scale. Evaluate the behavioral and physiological changes. As we said, you know, acute pain versus chronic pain. We talk about the chronic pain. The chronic pain, you know, because at some point, you know, when the too many messages or nerves start, you know, to get for this pain, eventually the biochemical markers in our body, you know, that the human body release in case of pain or stressors, these will not be, you know, any more alarmed or alerted. So they will get, you know, stop releasing noradrenaline or any of these biochemical markers, and the patient will not show any signs of stress, especially with the chronic pain. So acute pain will activate body's fight or flight stress response and all the hormones that get released. When pain persists, body begins to adapt, and this is a decrease in the sympathetic, you know, response. In a chronic pain, stress response is absent or almost diminished. Physiological indicates, you know, of acute pain. And what do we see in pediatrics when they have acute pain? We start to have, you know, increase in their perspirations, dilated pupil, increased rate, tachycardia, tachypnea, blood pressure will be a little bit high, decrease in their urine output, okay, and decrease in their, all these, you know, vasoconstriction because of, you know, releasing of the noradrenaline, and will cause, you know, decrease in the peristalsis, increased basal metabolic rate. This is the changes we'll see with the acute pain. Now in the neonate, what are the signs? Maybe because it's physiological variables, you might increase heart rate, respiratory rate, blood pressure, shallow respiration, decreased vagal nerve tone, pallor, flushing, diaphoresis, palmar, sweating, okay, O2 saturation decrease, EEG changes. This is exactly in neonate. If we're talking about behavioral variables in neonate as well, they might cry often, apneic spells, okay, groaning, moaning, okay, change in their sleep, awake cycles, and agitation or listlessness. Also, sometimes body movement, limb withdrawal, swimming, thrashing, rigidity, flaccidity, clenching of their fist. This is also a bodily, behavioral in neonate. So look at this, body behavioral as well when you assess for the neonate. The facial expression in pediatric as well, sometimes the eyes tightly closed or open mouth, squarish, foreign or bulging of eyebrow, quivering of chin, deepened nasolabial fold. This will be seen if they have, as a facial expression. Now, the immediate the consequences of pain in infant, it might be immediate, irritable, fear, disturbance, sleep, awakeness, and in a short-term effect, delayed healing, impaired emotional bonding, and in long-term, the developmental retardation, memory of pain, alteration in response to subsequent painful experience. And we can see, how bad these long, term consequences in pediatric patients. Okay, pain versus distress. Unfortunately, and this is, here's here where we can stress a very important point. Unfortunately, young children are unable to describe their sensation. So we have to guess when they are in pain, and we are probably not great when we guess that. And children who can communicate often rate their distress higher than their pain. So there's a rate of distress and there's a rate of pain. And if your pediatric patient is communication, sometimes they are stressed more than they are in pain. In a younger children, the inability to communicate means that we are forced to make assumptions. And I think, so this is one of the physicians, okay, we are, that creates an ethical responsibility. So this assumption, that the patient is in pain, assessment, whatever you try to quantify using the scale for the, will carry an ethical responsibility in the healthcare provider in order to assess the pain and quantify it and treat it. Pediatric pain management strategies. And this is maybe this is the take-home message for you guys. Perhaps the best strategy to reduce pain is simply avoid causing pain in first place. So if the pediatric presented to emergency, the golden rule is avoid, causing extra pain for them. Then later on, you can treat their, their pain. But the first thing is try reducing the pain by, adding more pain to them. So if they have one cause of pain, you don't add 3 or 4 causes of pain. And this is the most important thing. Be kind. Be kind to these, beautiful creatures. Okay, they get treated. They their pain relief with a small, kindness and small, cuddling or soothing techniques that may help, to calm them and make them comfort. I like to pause a little bit in this picture, okay, because this is, carries a lot of emotions and will always remind us as a healthcare provider that we are human, we have emotion. We need to think about this, especially when we deal with pediatrics. Don't you all agree on this? Okay, so let's start about this, the non-pharmacological techniques that we can use to reduce, calming them, comforting them. Breastfeeding, okay. Mother labs is a magic. Mother lab, has, will make them more comfortable, will make them feel more safe, okay, and will decrease the stress. Swaddling, facilitate tucking, rocking, holding, all of this technique will help, very likely to be calming and truly analgesic. However, they are probably comforting, limiting overall the stress, and so are valuable as adjuncts. So they are adjuncts to the analgesics. Distraction techniques, especially for the older kids, more than an infant, as visual books, smart devices, virtual reality, handsets, play either with a play therapist or guardian, blowing bubbles, conversation, interaction with a caregiver, having a smart pediatric rooms in a pediatric emergency. This will help, to distract the babies, the children, okay, and make their environment, okay, it play a major role, in comforting them. So if we think in building emergency department, pediatric emergency department, we think should having, make it like, their home, how they would like to see it, full of, safe, stuff that they can play with. Now, don'ts. Avoid, using language that falsely reassuring. Example, there's nothing to worry about. This is a vague, this won't really hurt. This is a negative. This will feel like a bee sting. The medicine will burn, don't cry. All of these, false, assurance, okay, actually to break up this trust between you and the children. And next visit to the ER, he will not trust any, physician, will not trust any nurse. So try to be, direct with them to the point. It will hurt, okay? It will, okay? But it will hurt maybe for 2-3 minutes, then will disappear. But don't tell them that it will not hurt, or it will hurt a little bit. Now, what are the preferred, routes for the medication? The oral, intranasal, topical, and intravenous are preferred routes. Intramuscular injection should not be used to manage pain except in discussion with the consultant because it causes more pain. Subcutaneous route is useful for children receiving palliative care or where IV access is extremely poor. Special consideration, we're talking about saccharose. I'm not sure if you all have it in emergency department, but this is sometimes it is available in the NICU, but some emergencies they keep saccharose as in case if they have especially infant less than 3 months, orally before performing painful procedure, heel break, blood sampling, eye examination, insertion or removal of IV lines, phlebotomy, insertion of gastric tube has been shown to decrease facial action associated with pain, heart rate, combined saccharose in infant less than 3 months. So if you have an infant less than 3 months, saccharose more effective if given with a soother, as this is promotes non-neurative sucking, with the contributes calming the baby. Acute otitis media, sometimes they're using lidocaine drops 1 to 2%. Still in the affected area, have the patient, with the affected ear up to 5 minutes. This will provide short-term pain relief, okay? And this is for ED use only. Do not discharge patient to take it home. Pharyngitis, dexamethasone showed, to give, effective reducing pain and decreasing, swelling in pharyngitis when adjusted as a conjunction with antibiotics. Corneal abrasial, tetracycline or, eye drops that will numb the area and decrease the pain, achieve analgesic effect. All of you aware about the EMLA cream, before accessing BAD, and sometimes using for distal blood supply, fingertip should not be used. But we use for IV, there's controversy about using this in a pediatric patient for EMLA cream, because it does actually decrease the pain, but also at the same time, it does do vasoconstriction, and maybe this will make the IV access difficult for the nurses. So it is a controversial using this for the IV. Fracture or dislocation, fentanyl intranasal, initial analgesia in children aged 1 year old or than moderate to severe pain. And this is a preferred route, especially because with the pain from the fracture, they will be crying, making them, with the IV, they try to do IV, they will cry more. So maybe intranasal fentanyl availability will help a lot in this case. Then later on, we can put an IV easy for them. Non-opioids, talking about, Tylenol, talking ibuprofen, indomethacin, ketorolac, naproxen for patient. And this should be used for only mild to moderate pain. And we're talking about opioid doses, about fentanyl, hydromorphone, methadone, morphine, and oxycodone. Okay, this is the frequency, the route, and the dosage for them, and should be used for moderate to severe. So noses are used more than just for smelling. Medication can be given, intranasally, as you see, and this is can, easily, without, trying for somebody who's crying from burn or from, fracture. Okay, this can be easily achieved with 1 minute and can have effect right away. Later on, we can try for the IV. These are the doses for the fentanyl. Okay, 1 to 2 mics, maximum is 100. Adverse effect is nausea, vomiting, may cause respiratory depression, midaz, and this is, as you all, sedative. Okay, and for sedation, 0.2 to 0.3 milligram. Ketamine, this is analgesic and also sedative. It can be used 1 to 1.5 milligram and 5 to 10 minutes, cause nausea, dizziness, and unpleasant taste. Now, the last thing we need to assure is about documentation. All pain assessment and reassessment should be documented before the pain and after the pain. Management education for the parent, as we should. Patient and family should be involved. Patient and family education about the side effects should be also explained for them, and patient have a discharge plan and discharge, about the pain and when they can come back, what are they expecting from the pain medication, how frequent this pain medication can be given. And the ABCD for the pain: ask about the pain regularly, assess the pain systematically, believe that the patient and family in their reports of pain, choose pain control options appropriate for the patient, deliver intervention in a timely manner, okay, and empower patient and their family. Conclusion from this, okay, the only reason to assess pain, and this is also another take-home message, the only time you assess patient pain is to take action to relieve pain. It's not about, I wanna take, assess them, document them, and I have no plan for this. Once I have in my head that I assess and put the plan, I need to intervene and give pain medication. After intervention, assess child response to pain relief measure, determine the timing of assessment on expected onset and the peak effect of intervention. IV analgesic, assess after 5 minutes and after 15 minutes. Final message: children, especially those who cannot speak, are vulnerable population whose pain is constantly undertreated. This is unacceptable, especially when considering a wide variety of treatment modalities that we have nowadays. All emergency physicians should be comfortable controlling pain in pediatric population. And remember, what is painful to adult is painful to infant and child unless proven otherwise. So we're done for this lecture. Do you have any questions? So guys, if we have no questions now, we can go for a break and we'll come back at 1 o'clock sharp, okay? of the difficult situation actually we face as healthcare providers when it comes to pediatric emergency is the vascular line. So we all suffer with a difficult type of patient who are, sick, especially with pediatric. Sometimes we ended up having no lines. Sometimes we wait for anesthetist to come. Sometimes they take them to OR for to insert a central line. However, there are some modalities can be used actually in case of, moderate dehydration or mild dehydration, where we can start subcutaneous rehydration therapy. And this is actually, as we will discuss in a minute, can be beneficial, to get, or restore intravascular volume in case later on if you want to insert, a peripheral line. It would be very easy and less time taking, after rehydration by the subcutaneous way. So what is the subcutaneous rehydration therapy? This is one of the modalities, and recommendation by Emergency Nurses Association to be used in pediatric emergency in case if we have a difficult lines or difficult babies. So the physiology behind this therapy actually goes to the physics, and the principles of physics about the osmosis, and where the fluid moves and the electrolyte moves from higher concentration to the lower concentration. So subcutaneous rehydration therapy involve appropriate function of sodium-potassium pump that will open, and will allow osmotic, pressure to occur in this, where concentration of fluid is greater in one area than the other area. And in this way, fluid can, sneak goes to the intravascular volume. So the subcutaneous tissue is a dense matrix of hyaluronic acid, which we call it hyaluronan, and it delays, the absorption of subcutaneous fluid into vascular compartment when the fluid is infiltrated. So actually, in the subcutaneous tissue, this hyaluronic acid will prevent the fluid from moving from the subcutaneously to the vascular compartment. So what we can do to make sure that the fluid will move easily to the vascular compartment, and the kids and the children can be hydrated and fluids can start to go inside or kick in the vascular compartment. The hyaluronate disease is a naturally occurring enzyme, breaks down in hyaluronan and allows a new matrix to form about every 24 hours. So this is what we will be injecting inside, the subcutaneous tissue. By injecting a small amount of hyaluronidase, 150 to 200 international unit, it's about 1 ml into the subcutaneous area. The matrix will be temporarily broken down and allow space to develop under the skin for the fluid to be infused more readily to the compartment, to the vascular compartment. So by breaking down this hyaluronan surface or hyaluronan layer by injecting this, hyaluronidase by 150 or 200 unit, it's around 1 ml. This will temporarily break down this hyaluronan layer and will allow the fluid, to easily flow from the subcutaneous tissue to the compartment, to the vascular compartment. Ultimately, the time of absorption from infiltrate to the vascular compartment and capillary is enhanced when the matrix barrier, the hyaluronate, is removed. As we said, you know, the idea is to remove this layer. The idea is to remove this surface where a fluid can be more, easily going from the by osmosis from the higher concentration to the lower concentration, and can goes, you know, in a nice way, in a smooth way to the vascular compartment system. So what are the indications? When do we use subcutaneous, rehydration therapy? When a parenteral rehydration therapy is needed for mildly to moderately dehydrated patient whom oral rehydration therapy has failed. So if you have a pediatric patient who's having vomiting, decreased oral intake, you try with him oral, you try with them Pedialyte, and they're not taking that, you give them some oral Zofran that did not work with them. They're still vomiting, not taking orally. So if there's a failure, for the oral rehydration therapy, and those patients should be, moderately and dehydrated, mild to moderately dehydrated. And this time, we can use the subcutaneous rehydration therapy. When patients with vascular access and life-threatening still require fluid rehydration. If they're still not in life-threatening situation and they require fluid rehydration, if they have patients who's having a difficult vascular access, but they are not in life-threatening situation, we will consider for them the subcutaneous rehydration therapy. So if you have a child again who's not in a shock state, not in a septic shock, who needs rehydration or fluid replacement or electrolyte replacement, and you're having difficulty inserting IV line for those kids, this therapy might be the solution for your case. Now, the contraindication for this, those were the indication. The contraindication is when you have severe electrolyte imbalance, indicated severe dehydration. As we said, the idea to use this in a mild moderate dehydration. Severe dehydration, shock, circulatory failure, fluid requirement greater than can be infused by a subcutaneous rehydration therapy. Infusion of area cellulitis, severe hyponatremia. So if that area having a cellulitis of the skin, if the patient having, severe hyponatremia, patient is septic, usually the skin is very cold. So process of, moving these fluids will not be easy, especially if the skin is not perfused. Sodium less than 130 and potassium is less than 3.5. This will be considered contraindication. Patient with now, or patient in an ICU, we won't be, consider this therapy for them. Now, patient who's having a bee sting allergy should be having a test prior to administration of human recombinant hyaluronidase, because usually those people who have, allergies to sting, that means, one of the components of this, sting allergy or sting, bites, or that they have, the hyaluronidase in their, combo ingredient. So if you inject them the natural hyaluronidase, this may cause allergic reaction to them. So make sure that they don't have sting allergy. How to do this for those patients, the appropriate site for selection involves, essentially any area where the skin subcutaneously can be pinched. So optimally between the scapula is a preferred site for children for several reasons. So any site in the skin can be benched, okay? Can be used for subcutaneous rehydration therapy. However, between the scapula, okay, at the back will be preferred for the children for many reasons. First, out of sight, out of mind. Kids, they will not see it. Family, they will not see it. It's going to be easily, okay, not take, they will not, concern about it. It provides more diffuse subcutaneous area than the other location for fluid disperse. Parent can hug, hold child during insertion, and there's no need for restraint for the children because, it is at the back and they cannot see it, they cannot remove it. The area is less sensitive to pain than the other areas. So there are many reasons, as we mentioned, to choose the area between two scapulas because of many reasons, and could be, easier to apply, easy to hold the baby. Baby will not feel the pain, and it have a lot of subcutaneous tissue that will allow, easily, transmission fluid to the compartment, to the vascular compartment system. How to do this? As you all can see in this picture, okay, they are benching the skin here, okay, and you see the needle here. So the use of an insertion device such as 25, you bring a butterfly needle, okay, it can be done, or 24 gauge catheters preferred. It's up to you, whatever is available, okay. This is more, can be secured, okay, more stable, 24 gauge cannula. The insertion device and the connection tubing should be gently flushed with 1 ml, as we said, 150 units or 200 units of hyaluronidase. With the skin and subcutaneous tissue bench, one should insert the needle quickly into the bench skin about at a 20 to 30 degree angle and check for blood return. If a blood return occurs, the needle should be removed and another site selected should be chosen because direct contact with the blood will inactivate the enzyme. So this is a very important point, okay? Make sure, guys, if you want to use this, okay, that there's no blood return. In case of any blood return while you're doing this procedure, just pull back, take it out, choose another, site where you have no blood return. The blood will inactivate the enzyme itself, and this will prevent, fluid from, migrating from the subcutaneous tissue to the vascular compartment system. You can see in this picture how is, the needle inside, okay? Prime the tubing with a subcutaneous needle with ordered, as we said, 200, 100 units, and prep the skin for needle insertion. You pinch the skin between the two fingers and insert subcutaneous needle. Okay, guys, sorry for this disconnection, okay. And so, as we said, we pinch between the two fingers, insert subcutaneous needle, 90 degree angle, okay, until flush with the skin. So you flush the skin with the with the hyaluronidase, secure with the transparent. You see there's a transparent dressing. Withdraw the syringe slightly to ensure that there's no blood retained. So as we said, you know, prime it with the enzyme, with the hyaluronidase, flush it, okay, insert it, and make sure that there's no blood retained. And after that, secure it with a transparent, you know, skin. Tegaderm. This is a different picture for the procedure, and where you can see that, you know, before insertion, and this is, you know, A, that's before the insertion, B at the beginning of the insertion, and later on at C. So if you can see, if we begin with subcutaneous fluid administration infusion pump, we can give boluses of normal saline, continuous maintenance IV fluid, dextrose water, normal saline, dextrose half normal saline, and start at 25% order rate, increase by 25% every 5 minutes until full rate 15 minutes. So if the rate is 100, you know, ml per hour, you're gonna start at the beginning with 25 ml per hour. Yeah, after 5 minutes, you increase it to 25%, you increase it to 50 ml percent. Full rate can be, you know, achieved, okay, by 15 minutes, okay, after the beginning. Now, expectation of red area, that's a normal, okay? It's a fist-sized infusion site for first 5 minutes after initiation. It's gonna be painless. Swelling will soften approximately, okay, and resolve soon after the completion. You see after this, you know, later on, this, you know, swelling, okay, will disappear. Now document the site Q1 hour, changing, you know, the site Q 24 hours, 48 hours, as we said, you know, the natural enzyme, okay, it has a window time to work for 24 hours. After 24 hours, you know, we need to break down again this layer and inject a new hyaluronidase. If it's clinically indicated for the site condition and following 1.5 to 2 liter fluid administered in 24 hours. Obtain vital signs, assess fluid status baseline after each bolus administration. Provider will reassist after each bolus and or 24 hours for continuous infusion and place, you know, a new subcutaneous order if indicated for that child. Now, this is, as we said, you know, it can be used as a bridge to, for IV therapy. In a journal, Emergency Nursing 2013, okay, compare subcutaneous fluid infusion with the intravenous fluid infusion in children with difficult IV access. They found, and this is very important, okay, the mean time from order entry subcutaneously to fluid infusion to be 20 minutes, and compared to failed IV access group with an average infusion start time is 1.5. So this means if you want to start subcutaneous, you know, rehydration therapy for a difficult IV, it would take you 20 minutes, you know, and the fluid will start, you know, to kick in. However, if you're looking for a difficult IV access, it may take up to 1.5 hours. Now, the most important thing, the latter group, okay, eventually received subcutaneous fluids, and the investigator also found shorter ED length of stay in the subcutaneous group. So it's proven, you know, in this study that, you know, this is a bridge. And the same study, subgroup received subcutaneous fluid initially and later on IV. They found a trend in ease of IV access after subcutaneous fluid therapy. So what was as difficult, you know, before, and the kids was difficult to start IV, after initiation of this, you know, subcutaneous infusion and fluid, now it became very easy, and you can see the veins, normal vascular, you know, volume restored, and kids, you know, they start showing some, you know, easy veins, so that can be accessed easily. Do you hear me very well? Are you with me, guys? Okay, excellent. Predicting difficult IV accession. Much has been studies written about predictors for IV difficult access in children, and every institution, hospital, they're using different, predictors or scoring to see if that, patient is going to be a difficult IV or not. So instead of wasting time looking for IV, it may be helpful to start subcutaneous rehydration therapy. An example of this, most, studies often cited, if an age less than 3 years, weight less than 5 kg, prematurity, obesity, darker skin, where contrast of vein to skin maybe not be apparent. So the three main predictors were validated by, this researcher in emergency medicine include the most practical universal features: vein valvability, vein visibility, and patient age. This is all, considered predictors for the difficulty of IV. Can we give medication in subcutaneous route? Yes, we can. Antibiotic can be given, okay. Pain medication can be given, okay. So it is a safe route where we can, restore patient, hemostasis. We can start antibiotic, okay, until we have, a good way or a good vein can be accessed for the baby. Questions: what if we don't have the fancy hyaluronidase? So what if you don't have it in your pharmacy, okay, or in your hospital? Can we use the subcutaneous? Rehydration therapy? It is actually increasing, readily found and available in a generic form. So if you have it, please use it, but it will make a believer out of you and others. Hypodermolysis will work without the hyaluronidase. The process of subcutaneous rehydration just takes longer time to work. So it does work, okay, but it would take time, and rehydration happen maybe takes more time. How long can you leave the subcutaneous line in? Okay, the longest time that subcutaneous line has been reported to be left in a patient has been about 48 hours. When the child was discharged from the inpatient unit, reports of leaving subcutaneous line in geriatric patients for longer periods have been published. In one study, the average duration for infusion was 15.9 days, with average of daily volume around a liter, okay, per day. So these are a good news, that we can leave these lines for quite sometimes, especially if you think about, we talked about the end life, care for pediatric who doesn't have poor access, so it is a way that we can manage their pain, we can hydrate them, okay, less painful, and it actually improve their experience, improve their pain, and it decrease the length of stay in the hospital. Can a fluid other than the normal saline ring-gel lactate be administered? Any fluid that contains normal saline ring-gel is acceptable. Example, D5 normal saline with a 20 milli equivalent KCl. A fluid such as D5 dextrose 5% water is too hypotonic and may affect the sodium-potassium pump mechanism. So that's essential for the fusion. So we will refrain from using the hypotonic solution. And as we discussed earlier, from physics point of view, the osmotic pressure, will decrease, and the fluid will not be able to move from the higher concentration to the lower concentration. So stay with a fluid that's considered, like a, crystalloid, and that will also have, a good osmotic pressure. Is it hurting? Does it cause pain? Is it more painful than the IV? Nerve endings are in the middle layer of the skin, which is pierced. Nerve fibers that run along the blood vessels makes intravenous line hurt more than with the insertion. With this method, the skin is pierced, but the needle goes into the fat. Subcutaneous tissue where there are few or no nerve ending. So this is also a good news that, you know, when it comes to pain, nerve endings are almost, you know, especially when you pinch, you know, the skin, they are not there. So they don't feel the pain. Because we use a very small needle, the pain is with pierce of the skin, which feels like a finger prick, but it's gone quickly. A topical anesthetic may be used to take away this pain. In summary, the Hyaron days or augmented subcutaneous rehydration therapy becoming an accepted alternative for children with mild to moderate dehydration when oral hydration has failed or intravenous access is difficult. So it is a good alternative, good way to use for kids while using, in comparison, using the nasogastric tube. I'm not sure if anybody, you know, tried as oral hydration, nasogastric hydration if patient is not tolerating, is accepted alternative, but you know, the technique is very invasive and usually requires restraining of the child extremities and can lead to complications. The use of oral, you know, omeprazole has enhanced oral rehydration therapy, but is not always successful. And we've seen a lot, you know, time that you may give the patient, you know, ondansetron and does not work with them. They do not take it. They did not swallow it, and you ended up having, you know, a patient with the IV. So if your patient is mild, remember mild, moderate dehydration who will require IV fluid. This is, you know, considered an easy way, less painful, and will decrease, you know, the time for the IV. No need to restrain the patient. It can be easily done. And the outcome will be, you know, better for the patient and for the family, and will be decreasing the lymph stage. This is in summary about, you know, subcutaneous rehydration therapy. Do you have any questions, guys?
Thank you, Dr. Hussein. Excellent lecture. Field in emergency department. Many cases came with trauma and with different fractures. So it's very important we have some experience how to deal with this patient, whose patient needs to be repaired, whose patient need to be managed in the ER and need to follow up later on. So my talk will be divided two parts. The first part will be talking about the upper limb, then second part will be talking about the lower limb, and will be cover all the types of fracture in the pediatric. Before starting to talk about any fracture, you have to be familiar for some anatomy for this. Any patient present to the ER, you know, the anatomy for pediatric is still different and distinct about different part. You have to be familiar when you manage the patient. You have to be familiar about this one, and how to describe that fracture is very important. So As you know, this is epiphysis and this phases and physical growth, and metaphysis, and this is diaphysis. This is diaphysis. This is very important, and metaphysis and epiphysis growth. And when you describe the fracture, and will be interrupt the growth plate, is very important to different management and different approach. So the blood supply, usually there is three different source of blood supply for that bone, periosteum, and some there is a blood supply came from that nutrition to the bone by epiphysis and metaphysis artery. And but about the infancy and before the closing of the growth plate, it can be there is other ring and circulation came from and supplied that growth plate through the transphase. The growth plate will be going and taking the nutrition and supply from the artery from the epiphysis and metaphysis arteries. So you know that physical growth or phases is the consists of multiple zone and rapidly dividing and not yet classified. So yeah, so it is very important in the growth of the bone. So when there is any fracture close this growth plate, so it's very important to be sure it's not make any interrupt the growth of the bone. So it's very important to consult the orthopedic before deciding if it's safely to go home or to be need to be seen in the emergency department and the orthopedic. So you know that development bone is thicker periosteum in the pediatric. So bone is more elastic, so that allow this is distinct feature for the pediatric and unique features. So a fracture type of pediatric is different than adult. Will be found the different type of this like torus and buccal fracture, grain stick fracture, bowing. You will not find this one in the adult age. And also this avulsion, because this is the tendon is more stronger than the bone, so it can be easy to see that's avulsion in the pediatric age. As you know, the Salter-Harris classification is the growth is one, you know, that's type 1. Type 1, usually you cannot find any radiological findings. So any patient present to the ER with the pain, and you cannot see any fracture in the X-ray, most likely maybe it's patient with the Salter-Harris type 1. So can go for PAX lab, and you can make good follow up with the orthopedic, even if you didn't see any fracture. Salter-Harris type 2 is more proximal to the fracture. The third one of Salter-Harris type 3 is distal. When you involve that all the proximal distal, this is the fourth. When you make crush injury to the growth plate is the fifth Salter-Harris type 5. And but the problem for this Salter-Harris 5, sometimes you cannot see anything on, and not seeing any finding in the X-ray like the Salter-Harris 1. It will go through that upper limb. You know that sometimes when you describe any fracture to the orthopedic and make good consultation for orthopedic, you have to describe if there's any displacement, any angulation for that type of the both ends of that for fracture, or sometimes you can be shortening, or there's override for this one, and so it's very important to be describe this one when you consult orthopedic. Also, other important thing when you approaching any patient with a fracture, to describe if this patient he has or she has some nerve injury. So you have to be familiar for that nerve supply for that upper limb. So you know that ulnar nerve will be supply, if you are speaking about the palmar surface of the hand, will be supplied for the little finger, and half of the ring finger is also for the palmar surface will be supply the ulnar surface. Ulnar nerve will supply both the palmar surface and dorsal surface. When you speaking about the nerve for sensation, the median nerve will be supply all the remain finger in the palmar surface, okay, and also the distal part of all the finger in the dorsal surface. The remain of the nerve supply in the dorsal surface will be supplied by radial nerve. So it's very important when you make good assessment for the nerve supply and the sensation. Is very, you have to be familiar for sensation and to be sure this nerve is intact or not, and you have to report and to mention in your consultation. Also, when you make good assessment for the nerve, you have to make good assessment for the sensory and motor. So if you are speaking about motor for median nerve, you have to ask the patient to make finger flexion. If you cannot do that one, then maybe there is motor injury for the median nerve. And also for radial nerve, you have to ask the patient to make good extension of the wrist and metacarpal phalanx joint to make good extension. If you cannot do that one, then maybe the nerve is injury. And a nerve, ask the patient to make a small muscle of hand. This one to make a good abduction and adduction for the finger. If you can do that one, the most likely this patient is good and it's intact, the motor. When you are speaking about anterior interosseous, this branch from median nerve, this will be ask the patient just to make good thumb flexion at interphalanx joint and flexion of the index finger to be sure this is intact, the motor of the anterior interosseous nerve. We'll start about the first type of the fracture, the clavicle. Clavicle, one most commonly fracture can be encountered in the pediatric. Usually, many cases can be present with this fracture after delivery. Can be present with this abnormal, is not moving the same side. So if you think about that clavicle fracture, and you have to be sure this is intact or there is any fracture. From 10 to 15% of the pediatric fracture, so it's not. It's very important and to be. It's very common, and this is the fourth bone fracture can be in older children. More than 90% of fracture of the clavicle is in the middle third. So if the patient presents with the middle third fracture, usually can be discharged the patient on a sling and for comfort for 2 to 3 weeks, and you have to manage the pain. You know, this is if we know and no displacement between the two ends of that fracture, can be excellent remodeling for this patient. You have to be informed and warn the parent about this bump can be developed later on. So you have to be the parent familiar for this one. This can be happen for this patient. So and sometimes can be if that's a lump can be increased in size, maybe can cause some scar in the skin. Need to be follow up in the family with the doctor after 6 weeks to be sure everything is done and everything is okay. You can take a long time to see that radiograph healing for this patient. This study then to be compared if you can compare between the as technique, all technique using that's figure 8 bandage compared to the simple just only sling. This done in the 79 patient random controlled trial for this patient. Found this is that simple sling caused less discomfort and perhaps fewer complication than the figure 8. So this functional and cosmetic for result for this is both method or technique we are identical, and the alignment of the will be healed. The fracture will be no change from the initial displacement. About proximal distal clavicle fracture. Proximal clavicle is not common in the pediatric. It's less than 2%, but if he's present, it's very important to consider this one. Usually involve the growth plate and maybe Salter-Harris type 1 or 2. But very important if there is any displaced posteriorly, maybe get tracheoesophageal compression, and so very important to go for CT scan and to consult the orthopedic. About distal clavicle fracture also usually is not common as the middle fracture, but middle third. Usually is involved the growth plates Salter-Harris 1 and 2. Often it's difficult to distinguish from that acromioclavicular joint separation. So you have to be grossly, if the patient grossly unstable, you have to consult the orthopedic and refer this patient in the ER. Shoulder dislocation, you know, the shoulder dislocation in pediatric, the most common type of the shoulder dislocation is anterior dislocation. Is more common than the other type, and what will be found in the examination usually loss of the normally rounded contour of that deltoid, so slightly abduction and external rotation for this patient. The humeral head maybe is bulbated anterior to the glenoid fossa. So you can do X-ray for this patient, trans axillary view to ensure where you can find that the head of the humerus, and you can provide adequate analgesia and relaxation before making reduction for this patient. There is different technique for that reduction of the shoulder dislocation, like traction and counter traction. And there is other technique, this scapular manipulation or external rotation technique. It's not common to see this shoulder dislocation in the pediatric age, but you have to be familiar, and for that problem can be encountered in pediatric, you have to be familiar for this one, and what's the good way for make good reduction for this one. Immobilize this joint after the reduction for 3 to 6 weeks, then you can begin rehabilitation for the patient therapy. Other complication can happen from that shoulder dislocation. Axillary nerve damage maybe can be happen for this patient, and you have to make good assessment for the sensation over the deltoid muscle pre and post reduction. It's very important to be sure any complication can happen after reduction or this happen from that dislocation. For humerus fracture, the proximal humerus usually can be seen from that age from 5 to 11 years old, and present usually with the Salter-Harris type 1 or green stick. Sometimes you can see the toes fracture. Patient usually, if you present with this humerus fracture, usually from that age, from 11 to 15 years, usually present with the Salter-Harris type 2 injury. So most of fracture heal well with the sling and swab. So close reduction attempt, and you can or you can go for operative treatment depending on the age of the patient, degree of the angulation, and the amount of the displacement for that fracture. Other problem can be seen and can be encountered the pediatric emergency, that humerus shaft fracture. Proximal and distal more common than the diaphyseal injury. Can happen with mechanism of direct blow to that area. Torsion fraction maybe can be evolved or severe twisted, maybe result from the spiral or the diaphyseal fracture. Mid-shaft fracture can be healed well if the angulation up to 15 to 20 degree. And or this can be if overriding only 2 centimeters between that two end of fracture. You can use the sling and the swab for this one for young children. If the patient is adolescent, you can use the sugar tank. Sugar tank is not maybe it's not comfortable for use in the pediatric or small age. So usually the sugar tank technique you can just use in the patient of near to be adult or adolescent age. Fracture involving the junction of the middle and distal third of that humerus may be associated with injury of the radial nerve. So this is the near the spiral growth for that radial nerve. So it's very important to be sure not patient with any injury to the radial nerve. So we have to make good assessment for the sensation and motor for that radial nerve. Usually fat pad usually in the elbow, if you present with a small fat pad for this one, you can accept it, and we think about it's normal for this one. So true lateral view for this one for elbow to flex at the right angle and to be sure this is normal fat pad or not. This can be accepted as normal, but if increase in the size like this, you can see this one is very large and this one is abnormal, but also any fat pad posterior is abnormal for this patient. Fat pad in the refusion, flat anterior fat pad is often present with the normal children, but it is bulging anterior to fat pad. See a sign, this will be always this abnormal. Anything posterior fat pad will be labeled this one abnormal. Other assessment, you can do the anterior humeral line. Anterior humeral line is very important to be familiar for anterior humeral line. You can just make a good line for this one, imaginary line. You have to be intersect of the middle third of the capitulum distally. So you have to make a middle third of the capitulum distally. If you make that anterior humeral line, to be sure, if you cannot do make good intersect for this one, you think this patient maybe has some supracondylar fracture. Other, you can do the radiocapitellar line. The radiocapitellar line, this will be any you can imagine a line within the you can doing from the radius and the mid of this point, this to be make imaginary line for this one. If this is that radiocapitellar line is not make bisect the capitulum, even you change this position or this is change of flexion or extension for this one. If you not do like this, this may be this patient with occult radial neck fracture or radial head dislocation. Okay, supracondylar fracture. What you have to do, this is common, maybe around 50-60 of elbow fracture from the age of the 3 to 10 years old. Usually the mechanism usually is push technique, push presentation for this patient. That's falls onto outstretched hand. Can be divided this one, or can be classified this one to 3 type. The type 1 non-displaced, displaced, minimally displaced, or for this one, and type 2 is displaced but hinged on the posterior cortex. 3, there is no any completely displaced and posterior cortex. They are disrupted, so you have to beware of that compression of that medial column. This one, the type 1, you can see there is a fracture in this area. So usually, like this one, you can send the patient on the arm sling or back slab. Okay, and you have to be followed with the orthopedic. This patient type 2, usually this is still connected in the posterior or hinged by this one, so it can be going to be complete. So it's very important also type 2 and type 3 like this. You have to be consult orthopedic and to discuss with them and to be sure about the neurovascular is intact or not. So very important. So type 1 supracondylar fracture usually can be managed with the casting. Type 2 and 3 fracture, you require operative reduction and internal fixation. Most children with the type 2 and 3 are admitted for 24 hours for observation, okay, and to be sure the neurovascular status for this one and the extremities you have to be reassessed frequently to be sure there is no any change in the vascularity and the nerve supply. Over reduction and the internal fixation maybe can be necessary for this one. It's very important to be very, very familiar for that patient. What's the complication can happen for this patient? Neurological injury can happen for this patient. Can be happen from 8 to 15% of the patient with the supracondylar fracture, like anterior interosseous branch or median nerve injury. Radial and ulnar nerve can also be involved or injury. Radial artery, if you patient present with the type 3, can be 50% of this patient. So it's very important. Also think about compartment syndrome can be happen as a complication of supracondylar fracture. Longer term, cubitus varus, this cubitus varus, this one that will be the hand is in, and this is the normal. Cubitus valgus will be the forearm will be make angle outside this one. So if the patient with the cubitus varus would be going this, and the angle of that forearm would be inside. So one of that's complication, long term can happen as a complication. Volkmann's ischemic contraction can be happen for this patient due to the interrupt or injury for the vascularity of that near to the elbow. So other important to be familiar for this one, lateral condylar fracture. Condylar fractures can be 15 of the elbow fracture, usually present with the Salter-Harris 4. Big age from 4 to 10 years old. Presentation, same, that's falls on outstretched hand, not usually associated with the acute neurovascular injury. What you requires aggressive intervention to prevent lateral complication can be happen for this one, like what? Non-union or lose of the elbow mobility and growth arrested of the lateral condylar phases. Ulnar palsy like cubitus valgus. Also can be vascular necrosis can happen for this patient, and usually sometimes can be fishtail deformity. Fishtail deformity can, like this one, is the necrosis or ischemic change in that elbow, and can present the patient with the present a fishtail deformity and affect maybe the mobility of the elbow. Management usually operative for this patient. You can see this is lateral condyle fracture. It's very clear, and there's a lateral view for this one. The patient cannot make good angle of that view, so it's very important to consult the orthopedic. Medial epicondyle fracture usually seen in the adolescent boy, didn't involve the joint surface. You have to check for the ulnar nerve because it's very near to the nerve, ulnar nerve, so it can be easy to be injured. And so it's very important to make good assessment for this patient. 50% associated with the dislocation. So what the treatment, very important for this patient, usually non-operative, while the severe displacement can be discussed with the orthopedic or ulnar nerve injury, can be discussed with the orthopedic for immediate intervention and maybe going for operative management. What about the forearm fracture? The radius and ulna are the second most frequent injury bone during the childhood, around 50% of that for all fractures. 3/4 of all injuries involve that, third of the distal third of the forearm. Like what's important for this one, you have to be familiar when you do this patient, you have to be keep leave alone or need to be the make good reduction, or can be consult the orthopedic. About proximal radius fracture, most commonly between the age from 8 to 12, usually involve that metaphases or metaphases or phases or not that radial head. Salter-Harris type 1 and type 2 radial neck fracture are most common. Salter-Harris type 4 radial head fracture may be encountered in the older children, and abnormal fat sign of the abnormal redo-capitular line can be present. Alveolar fracture, usually commonly in the combination with the other elbow injury for this patient. Management, if less than 15%, angulation, posterior slab, and follow-up with the ortho. 15 to 30% posterior slab for this patient, early to go to ortho. More than 30, you have to go for immediately for maybe admission for this patient. Montijo fracture is one other important, we have to be familiar for this one. The Montijo fracture, what's the Montijo fracture? This ulnar fracture with the proximal radio dislocation. This can happen plastic deformation of that ulnar, and okay, the 15% for this one. From the 8 to 70% associated with neurological deficit, and usually a posterior anterosseous branch of the radial nerve can be injury. Management called the orthopedic for this Montijo fracture. Midshaft radius ulnar injury, you have to make a good reduction if the patient any radial ulnar angulation, any rotational deformity. You have to measure that angle for this one. If it is infant, accepted around 25-50%, children around 10%, but the important, if there is pre-pubertal age, is need to refer the patient to the orthopedic, because the remodeling take time, maybe around 2 to 3 years old, but it is from that fracture. What's acceptable displacement for any fracture for this patient with the midshaft? Acceptable if young, and this patient with depend on the age for this patient, and also what's the angulation for this one, or and the displacement. If it's minimal displacement, you can accept it for this patient. Other important bone deformity for this patient. This will not be remodeled. This is one of difficult part. If the patient present with the bone deformity, must be reduced if visible deformity or restricted any range of the motion for this patient. but still difficult. So if attempting to make reduction, check for all that supination and pronation to be sure there is not loss of this movement and range of movement. In a situation like bone fracture, you have to be consult immediately for the orthopedic. Other type of fracture, usually the Salter-Harris type 1, if you are physical injury for that radius for distal part, usually Salter-Harris type 1, 2. If you displace posterior, like Colles fracture or Colles type, or Smith's type is common, but this is anterior displacement. Smith will be displaced anterior, and posterior Colles fracture will be displaced posterior. Smith is not very common in the pediatric, and complication is uncommon for this one. Usually the Colles fracture can present like the fork shape, so you have to be familiar. For this Colles fracture, like this is fork, looks like the fork shape. About the Smith will be displaced anterior. Physical injury of the radius, when you have to go for reduction, you have to be very familiar for this problem, and you have to be very close to the anatomical angle. Normal, the angle for this one from up to 11 polar tilting of the distal of the radius. You have to want to be angulation at least not natural, and they had minimal displacement for this patient. Need be good modeling for this one, and about to maximum to be 11% of this degree will be keep that polar slab for this patient. You have to call the orthopedic if unable to correct the dorsal angulation or more than 10% of displaced. You have to call the orthopedic for a correction. Kalayazi fractures, other presentation that can be seen that the pediatric emergency department, but it's always it's very rare to be seen that kids. Radial fracture with the distal radioulnar dislocation. This is opposite from that tissue fracture. You have to call the orthopedic for consultation, and maybe this for admission for fixation. What's the difference between the metaphyseal injury of the radius? You can encounter the pediatric emergency as buccal fracture or grain stick or complete fracture. What's the difference between grain stick and buccal fracture? Buccal fracture, usually the other side is intact, the cortex. But when you see this is the grain stick, there is angulation from the other side. So that's grain stick. And if we are speaking about complete, both sides is involved for and the fracture. Which one more serious? Buccal fracture can be just only because, as you mentioned, this cortex is in opposite sides must be unaffected. These are a stable fracture. Grain sticks can be changed from the grain stick to going to be complete fracture, and it's one side is pinned to the other. So this unstable fracture, this tend to be moved back and position, and maximum deformity can happen for this patient. About distal forearm fracture is most common orthopedic injury in children from 6 to 12 years old. Can be present to patient with the history of mechanism of that fall on the outstretched hand. There is tenderness over the physial and can be present with the normal radiograph suggest for non-displaced Salter-Harris type 1 injury. Torus fracture, usually management can be treated with the removal or removable splint for around 2 to 3 weeks, and you can there is any having a complication or increase the pain or any concern about this one, you have to be going back for orthopedic or in the ER. This is for apocalyptic and complete fracture. Really an inner angulation, and you have to go for reduction. Rotational deformity, you have to go also for reduction. You can accept the angulation around 30 for infants, children around 15, pre-pubertal. Usually it's very interesting and very important to be not accept any angulation for this patient, because it takes time to make remodeling for this growth. Scaphoid fracture is not common in the pediatric, but you have to go to familiar for this one. Scaphoid fracture are the most commonly encounter of the carpal bone fracture. Usually mechanism like fall on outstretched hand. There is present with the limitation of the range of motion from that pain and swelling and tenderness in the anatomical snap box. Apply just only short arm, thumb, spica, splint, and refer to the early orthopedic evaluation. What about the metacarpal? Metacarpal, usually the neck is the most common area to be fractured. Most metacarpal fracture are non-displaced, minimally displaced, may be treated initially with the splint and immobilization and sent home. Displaced fracture can be generally be treated with close reduction and splitting. Other fracture like boxer fracture, when that's fracture in the fifth metacarpal bone, just striking someone with a solid object with closed fisted hand. Usually that's close reduction more than need the close reduction for this patient more than 30 to 40 degree of angulation. Usually can send patient with ulnar gutter splint, and you have to consult and refer to the orthopedic. Rolando fracture is, this is the Rolando fracture can shape T shape or Y shape. This is the comminuted interarticular fracture through that base of the first metacarpal bone, first bone forming of the thumb. This fracture is consists of three distinct fragments. It is usually with the shape, as you mentioned, this is a T or Y shape. The Rolando fracture is less common than the Bennett fracture and associated with the worse prognosis. What's the mechanism? This is just only axial force applied to the thumb in flexion position or fisted hand. Usually present with swelling and tenderness on the base of the thumb with the limited range of motion. Patient will present with a pain. You have to be sent with pain control and immobilized with the thumb spica. Majority of require operative management to manage any complication can happen for this patient. Bennett fracture is the fracture of the base of the first metacarpal bone, which can be extended to the carpometacarpal joint. The interarticular fracture usually is the most commonly type of fracture with the thumb, but nearly to be always be accompanied by some degree of the subluxation or frank dislocation of the carpometacarpal joint, but it's less than complication seriously from that Rolando fracture. Scales injury that can happen for that area. This with skating, or there is any snow for this one. I can call this one also gamekeepers. Is tear of ulnar collateral ligament of the thumb. These injuries happen when that thumb is pulled back to the side away from that finger. It's also often happen when the scales fall on the outstretching of the hand and the holding the sky ball. So this is tear usually with this one, and partially or complete tear for this ligament for this patient. About middle and proximal phalanx, this is fracture is usually in the Salter-Harris type 3 fracture, and is commonly fractures with the little finger, and proximal phalanx result from that extra active finger with usually with the ulnar displacement. This you see, this is the fifth one. Fingers will be displaced to the lateral side or ulnar side, and there are have to be reduced by flexion, and the metacarpal phalanx joint you have to make good adduction for this finger and make a good splint. Minute injury, other injury can be encountered in the emergency caused by the effulsion of the extensor. What? Extensor tendon from the distal phalanx of the, or from the fracture of the dorsal base of the distal phalanx. Well, how is that person present? Usually with the extension lag at the distal interphalanx joint present to the emergency, and this patient usually unable to actively extend the distal interphalanx joint. So children with the usually present with the Salter-Harris type 1 or 2 fracture. So the adolescent usually present with the Salter-Harris type 3 fracture. What you have to do for this: close reduction and splinting and slightly hyperextension like this on this side for this one. This is first part of my talk about the fracture of upper limb. Now we'll move to second part of fracture, the lower limb. Okay, my second presentation for me today will be speaking about second part or lower limb. Very important, you have to be familiar. Some fracture can happen for the lower limb. So we'll start with the pelvic fracture. Fracture of the pelvis are quite rare in children. So as usually when patient present to the ER with the pelvic fracture, usually as part of multi-system trauma like motor vehicle accident or significant falls from height. So usually patient present with the pelvic ring fracture, you have to be sure the patient stable or unstable. A stabular fracture are rare in children, but almost is associated with the hip dislocation of this patient, but it's rare, and you can see in our counter in the pediatric emergency department. What you have to do for this patient, you have to make good X-ray for the pelvis, are part of most trauma to protocol for this patient to be sure this patient not has unstable pelvic ring. Good outcome for this patient. You usually will go for conservative treatment, non-surgical management for this patient present with the pelvic fracture. If the patient is unstable, what you have to drop this one, and you have to stabilize the patient. It's very important as a part of the TLS. Fulging fracture of the hip. I mentioned in the first one of that's unique and distinct in the pediatric, the muscle and tendon is more stronger than the bone. So the fulging for this patient and fracture can be presented in the pediatric in some area when there is an traction of the muscle for that visits for this patient. So can present in the ischial tuberosity common in the more common than the other part. Also anterior inferior iliac spine, also anterior superior iliac spine, pubic symphysis, and iliac crest. There is different types, but the more common fulging fraction, this is ischial tuberosity. What you have to do, just only initial rest, then progressive range of motion and strengthening of the exercise can do later on. If painful non-union or displacement more than 3 centimeters maybe require surgery and fixation. This other example for this one, like elicrest can be happen from the abdominal muscle, can be make good fulgence for this one. Anterior superior iliac spine fulgence for serratus muscle, and also rectus muscle femoralis can be with anterior. If inferior iliac spine can make good traction for this part, can make fulgence. Lesser trochanter by iliosuous, also greater trochanter by gluteal muscle, civis pubis by abductor group. So you have to be very familiar for this one, and where is the patient complaint. Hip dislocation is rare in the pediatric. Less than 5% of all dislocation can happen in this age group. Patient will present with hip dislocation, usually falls or sporting injury due to the shallow acetabulum and increase the joint laxity, so can be present with the dislocation of the hip. Severe discomfort and shortening of the leg and flexed hip in the internal rotation. Usually the posterior dislocation without accompanying fracture should be reduced with the 6 hour by flexing of the hip to 90 degree and provide axial traction to the thigh to make good reduction for this patient. Leg calf bear disease present every 3,000 cases of children represent one case. Boy more common the girl. The peak age from 4 to 9 years old. Usually, some find there is familiar link between these 20 of cases. Pathophysiology usually present with a vascular necrosis of the femoral head with the trabecular collapse and secondary growth disturbance and deformity. What's the leg calf bear disease can present with this patient? Present with this pain in the area of the hip, refer to the knee. What the sign? Patient shies walk with the limping and decrease the hip range of motion. You have to request image anterior posterior for frog leg view for this hip to be sure that this patient know any change in the contour of femur head. You can see this is the contour of this one is changed with this one compared to the right side. Also this one, left one compared to the right side. So it's very important. This late disease, early disease, and so can be widening of the articular cartilage and appear this joint space will be widening. You can see this articular space, see if it is wide in the for measurement. So it's very important. If you find there is the contour of that femur is irregularity or is not lost of that flattened shape for this one with the time, is very important to consider and to follow, make good follow-up with this patient. Leg calf bear disease, you can see this case of vascular necrosis for this one, or sometimes you can see the crescent sign for this one with this patient. It is lost of the vascularity, and this one will be the contour of this is of femur will be lost compared to the normal one. Leg calf bear disease, difficult management is not. You have to be refer the patient with the difficult management. You can refer. You can send the patient with bracing and casting for about 1 to 2 years. Surgery will be allowed child to back to the activity within 4 to 6 months. What's the complication can happen with this patient? Severe the degenerative hip disease in some cases and require hip replacement with the middle age in 50% of cases. Other presentation, you can see the slipped capital femoral epiphysis, usually incident for per 100,000 cases. Adolescent age is the common age during the growth spurt. Black people is more common than Caucasian people. Also, there is a risk factor like if patient is obese or increase the weight. Also, usually this patient present with this Skype usually is tall with the cylinder shape, is risk more factor for that presentation. What the pathophysiology, the femoral head is move or slip with the respect of the rest of the femur. So the head of the femur will be stay in the cup of that hip joint while the rest of the femur is shifted. So usually occur before the growth plate close during the maximum growth spurt, usually in the male between 13 to 15 years old, female from age 11 to 13 years. What's the classification for this one of that SCIFI? Usually as present with acute or acute and chronic or chronic. Usually the classification by stability can be present patient may be stable or unstable. Most of the cases stable, around 90%. So patient present with the stable SCIFI, usually history of intermittent limping with pain with severe several weeks or month duration. Often poorly localized to the thigh or to the groin or the knee for this patient. He's referred pain for this area, so sometimes can be mistaken and cannot localize what is the tenderness. Hip pain is reported less frequently compared to the other area. So vague histories, sometimes difficult, sometimes we didn't know is it secondary trauma or not. As the epiphysis continues to be slipped, the child loses of the hip motion and increase the severity, including the internal rotation and deflection and abduction. For unstable SCIFI, present with the extreme pain, often after the sport or related to the trauma or from that twisting injury. Most of the children have no prior history of symptoms. Much higher rate of the vascular necrosis can happen for this patient related to that disruption of the epiphyseal vascularity. So it's not uncommon. This can be present with the vascular necrosis and loss of the contour of the femur head. SCIFI presents usually with the hip held on the abduction and external rotation and limited internal rotation. So what you have to do, you have to go for hip X-ray and anterior posterior frog position. You find widened epiphyseal plate and displacement of the femoral head. You can go for clean sign. Usually you can make a draw line for this one under the calculated to counter. If this is the line of the clean line is the intersect of that head of the femur, like this one is normal. For this one is, you see this clean line is cannot be not intersect of that head. Usually this is think about SCIFI or slipped of that femoral epiphyseal. Also this one clean line, see, is not intersect of the head. Also this one also. Usually sometimes come by bilateral. So often bilateral is careful with the weight bearing for this one. Stable, you have to strict non-weight bearing, refer to the orthopedic surgery next to 1 days for this one, and stable, strict non-weight bearing, and you have to admit for orthopedic consultation. What about the proximal femur fracture? Less than 1% of the fracture around that hip Complication can present with the premature physical or closer and avascular necrosis, orthopedic consultation, fulgence, fraction of that greater and lesser trochanter. Femoral shaft fracture can be present in the middle third of the femoral shaft. Assessment of neurovascular stats very important role. If there is pain, they have to control the pain and splinting before that radiograph evaluation. So don't send the patient to the X-ray without splint and management to the pain, because patient present with severe pain. So what you find in the radiograph should be include that femoral shaft and also the hip and knee to look for the possible of this dislocation and accompanying injury. So orthopedic should be involved in the hip spike cast, and surgery, the majority of this is injury usually going with the surgery. So we have to inform any patient with this fracture, you have to inform the orthopedic immediately. Fracture of the knee, commonly injury in the sport and fault or motor vehicle accident, is very high risk of growth arrest or progressive deformity when this either this is region or are involved. The distal femur, the Salter-Harris can be present with the Salter-Harris type 2, require reduction and occasional binning for this one, and to be sure for surgery for to be sure this anatomical alignment is present with after the surgery or fixation. Proximal tibial fissure is rarely a fracture because it is protected by fibula and insertion of the medial collateral ligament and distal to the physis. This one can be protected and less likely to find any fracture in this area. What about the fracture in the patella? It's rare. The large amount of the cartilaginous padding for this patient. So the examination of the knee, and you can go for palpation of the bony prominence and for physis and collateral ligament and distal pulse to be this risk for injury to near this popliteal artery. So it's very important. Go for anterior, posterior, and lateral X-ray and patella view to be sure this patient no any fracture or displacement fragment. Immobilization, non-weight bearing, and follow up with the orthopedic and the sports medicine physician, and after 35 days. Let's go shelter disease, other important the adolescent age, during the growth of sport boy more than the girl. This is traction along the tibial tuberosity from that extensor mechanism. So this is the tibial tuberosity. This is traction for this one. So commonly caused by knee pain and active adolescent. Usually can be present with bilateral up to 25% of patient. Management, supportive ice packing, and non-steroidal medication. Self-limited condition that will be fluctuated in severity over that 1 to 2 years period. What about the knee dislocations? Rare in the children. The high risk of this popliteal artery damage if there is any dislocation in 40% and peroneal nerve injury in 33%. You have to think about the patient with the knee dislocation. Think about reduction for this patient and admission for frequent neurovascular assessment to be sure this is not fault and there is no any injury for the nerve and the artery. Patella dislocation common in adolescent, lateral dislocation usually that's presentation. Reduction can occur spontaneously with the knee in extension position prior to the examination. You can repeat X-ray for this patient to be sure osteochondrial fragment from that sharing of the patella and femoral condyle during that dislocation. Sorry. Fracture along that shaft of that tibia and fibula. The most common long bone fracture of the lower extremities in the pediatric require in high energy mechanism. Risk of this compartment syndrome can happen, and ischemia, especially in that if the fracture is more in the proximal where the tibia artery is easy to be damaged and easy to be injury, and as a part of as a complication for that fracture. Tubular fracture, other important presentation for pediatric can be present with occult fracture. This one like spiral, this one commonly in a young child with limping and refuse to walk. If the patient in this age, tubular age, is present to the ER with cannot bear his weight and he's difficult to walk, think about tubular fracture. Low energy mechanism, spiral fracture of the tibia, oblique radiograph, unimpressive exam. So it's very important to be sure the patient not present with that tubular fracture. You can keep the patient cast for above knee for 3 weeks and follow up with the orthopedic. What about the fracture in the ankle? Most common mechanism for fracture in the ankle is the inversion of anticipation, which can place in the great deal of the stress on the distal part of the fibula facies. Okay, most fracture of this distal fibular facies are non-displaced. Okay, this distal tibial phase is most commonly injured in the Sub-Saharis type 2. So requiring reduction maybe is accompanied by the grain stick or of the fibula. One of the important, you have to be familiar with the Ottawa rule for the ankle and also the foot. If the patient presents with the pain after the trauma in the malleolar zone of the ankle, if yes, just check for any tenderness, bony tenderness at the posterior edge of tip of that medial malleolus, or bony tenderness at the posterior edge of tip of the lateral malleolus, or an ability to bear weight immediately after the injury in the emergency department. 4 steps, cannot make 4 steps. So if yes, you have to go for ankle X-ray, okay, anterior posterior lateral and mortis view. For the tower for the foot, pain in the mid-foot zone. If yes, you have to go for palpation if there is any bony tenderness at the base of the 5th metatarsal or bony tenderness at the navicular or an ability to bear his weight immediately after the injury, or this cannot be make 4 steps. If yes, you have to go for foot X-ray, series of anterior and lateral view for this patient. Distal fibula usually present with the Sub-Saharis type 1. Clinical diagnosis is very important. Widening of the X-ray often not be appreciated. If unsure, you can keep the patient on posterior slab, back slab, and follow up 1 week for reassessment. If fairly sure the patient, you have to go for below knee cast for 3 weeks, and walking cast is okay also for this patient. What you can see here, this patient with tulo fracture. Tulo fracture can present tulo fracture is of anterolateral tibial epiphysis that's commonly seen in the adolescent before the closing of carotid plate. So this fragment of faults due to the strong anterior tibiofibular ligament in this area, an external rotation injury of the foot in relation to the leg. So low threshold, you can, if you are doubting about this one, you're not sure about this fracture, you can go for CT scan. Call orthopedic. Need close reduction, maybe attempt for this patient to be sure this patient not missing. Will accept maximum 20 millimeter displacement. Otherwise, you have to go for fixation and reduction. What this one? Triplane fracture, other type of fracture. You can see this total fracture with certain Harris type 2 in the tibia, distal of the tibia. So the mechanism is force external rotation of foot on the leg. Basically, this is as a pediatric fracture for this patient. This triplane for this one. Triplane is okay prior to the physical closure for age 12 to 15 years old for male. Commonly than the pediatric, usually significant growth plate damage. 50% is fibula is a fracture. What you have to do for this one, usually have to admit ortho evaluation, CT scan, usually close the reduction in 30 to 50% possible reduction for this internal fixation. Foot fracture, the majority of the fracture in the foot for foot is metatarsal bone, usually due to the invasion of the ankle, direct blow or twisting force or force and this one. So there is the difference of Lisfranc or Jones fracture, usually the avulsion of the base of the fifth metatarsal seen during the ankle invasion injury. You can see this is injury and this is the fifth metatarsal. They are in a pediatric, but you can think about, you have to make good reduction when necessary, immobilize the patient in posterior splint and non-weight bearing for this patient. This frank fracture, either to be torn ligament of or broken bone in the midfoot area, like tarsal metatarsal for this dislocation fracture on marked tenderness in the swelling of the midfoot for this patient, and you have to come present with the oblique and weight bearing view for this patient to be sure this patient did have Lisfranc. So you have to consult and make surgical fixation with the orthopedic. Other calcaneus fracture, also it's rare to be found in the pediatric, but you have to be familiar about this one. Can be presented with patient with the present with the fall from that significant height. You have to do anterior, posterior, and lateral and axial view for this patient to be sure there is no any fracture for this patient. Talus fracture, this is talar neck fracture, commonly site fracture after the force, the dorsiflexion. You can see anterior and ankle pain, swelling with the inability to immobilize. Posterior, this patient posterior splint for this one and weight bearing, and follow up with close follow up due to the risk of the osteonecrosis can happen if you will not make good follow up for this patient. Now I open now the floor for any question about the orthopedic. Any question about the orthopedic upper or lower limb? Any question about okay, thank you. Any question you can send to me or email me, and this will be recorded. Both the lectures will be recorded and sent for everyone, and they will receive this recorded copy for this one lectures. Thank you very much.